stenting, talking about findings in May-Thurner syndrome. Geraldo?
Thank you, Dave.
One moment, please.
So I was giving the topic of various presentations of the May-Thurner syndrome, and in thinking about how I would approach that, I decided to first talk about the May-Thurner syndrome as we all understand it. It comes under different names. Some of them are descriptive of what the underlying pathology are. Other names that have been associated with it may include subsequent thrombosis. But it is a underestimated condition because it's probably a normal variant. Is probably the reason that we have a higher incidence of deep venous thrombosis on the left side than we do on the right side. And this was actually, as an entity, described first in the literature in 1851. Now, the traditional thought is that May-Thurner syndrome is caused by compression of the left iliac vein by the right iliac artery, the common iliac artery. So the left common iliac vein compressed by the right common iliac artery. It is probably more common in female also because of the increased lordosis in the lumbar vertebral column in female. And this is a picture that I took from radiographics that demonstrates this in a nice drawing. May-Thurner did cadaveric examination in 1957, or published on it in 1957, and found that based on his criteria that 22% of the cadavers, 430, did have a compression of the vein. And he also came up with this three categories of the pathological findings in the common iliac vein. A spur that comes from the walls laterally, a medial spur which actually divided the vessel, and then a variety of diaphragmatic looking obstructions, not occlusions of the artery. And this is depicted here in a different drawing that I've also borrowed from a different magazine. Well, is it possible that there could be something else going on? Is it possible it is not only the compression and the subsequent scar formed by the continuous hammering of the vein by the pulsation of the artery against the spine? Is it possible that if you go back into the embryology and think about how the cardinal veins and the merger of the right and left and subsequent development of the left and right common iliac veins has something to do with this? This is a complicated and delicate development. We know that patients develop venous malformations that are also thought to be due to changes or changes during embryological development. So it is not far reached to think that these similar things or things that are at that level, so to speak, could occur also in this anatomic location. And I just throw up this fairly typical finding that we often find in patients with what we call May-Thurner syndrome. Almost look like those are multiple channels. This is like a river coming into the seashore. It spreads out. It is much wider than you would have expected to be if it was just caused by the compression. Not that I would exclude that. And you could, yes, say that there may be some synechias that are responsible for this as a result of the scar tissue. But if you allow yourself to feed your imagination, you could also think that this has a deeper and much earlier source or cause. Now this is what we traditionally think is going on. It is entrapment of the common common iliac vein and subsequent intimal hyperplasia, scar tissue, and that the vessel actually get adherent to each other in areas causing these synechias that we so fondly talk about. This would be a very typical example of that. You clearly see the impression here of the common iliac artery as it crosses in front of and presses the vein against the spine. And you can see clear signs of the venous hypertension that occurs beyond that, where the blood finds a way into the deep venous system or the deep iliac vein, internal iliac vein, try to escape and find an easier route up to the heart. This is another example. This patient is actually lying on her or his stomach, so what is on the right here is actually on the patient's left, but here you can see the obvious spur. Here in the very central common iliac vein, and this would be another very typical finding. This is following thrombolysis, and this was subsequently treated with balloon alone, and this patient did actually well. But this would be a very typical finding for a spur or septation, as opposed to the image I showed you before. Now, we do use ultrasound, intravascular ultrasound sometimes, and we did that on this peculiar case with this broad common iliac vein. We placed a 16 millimeter stent, and I just want to point your eyes to this area here where the 16 millimeter stent is completely filling the proximal common iliac vein. But see how big the vein is central to that. Just adding to my notion that this is not just a normal vein that has been compressed. There is something else going on here. And this is opposed to the other case, which we have very typical findings of common iliac vein compression, and we stent it, and it doesn't have the same form. So Neglan and Raju, which have been publishing on the management of iliac vein occlusion and obstruction, came out with this very nice paper of 319 patients, all of which had obstruction of the iliac veins and subsequently were treated with iliac vein stents. Some of them had superficial or deep or combination of these reflux in the limb, but they did not address that at that time. I'm not going to go into the outcomes of this as far as clinical outcome. Those were patients that were in their 40s and 50s. But just want to mention that let me see, I'm getting... Mention that they had a high prevalence of compressions in these group of patients, and they came to the conclusion that not only were we dealing with a May-Thurner syndrome, as we typically would think of it, that is in the common iliac vein, but there were other pressure points. And they called them pressure points because they are fixed pressure areas. For example, on the left side where the internal iliac artery goes in front of the common iliac / external iliac vein and causes compression there. And also on the right side, the common iliac vein and subsequently the internal iliac proximal external iliac vein artery crosses the right iliac vein and causes compression of that. This would not be typical for May-Thurner syndrome as we understand it, but would be, we wouldn't call it maybe May-Thurner syndrome, but it would fall into many of the other names that we use for this condition. This is another picture from their paper demonstrating a narrowing where the iliac artery crosses here on the left side in front of the iliac veins. And they stented many of these lesions both on the right and the left and had clinical improvement in these patients without addressing the reflux below. And this is just a patient of mine, which you could see with intravascular ultrasound that there appeared to be a narrowing in this area. So I think that we do not still appreciate the significance of what we call May-Thurner syndrome. It is probably has a much bigger role than we think. But I also think that there are other conditions in the venous system that cause fixed stenosis, which only become significant when the patient uses his or her limb and thereby increases the blood flow and demand for a good outflow from the limb. I do not know if the etiology is still fully understood. There may well be a embryological factor in terms of the development of the veins, and there are definitely seem to be other anatomical structures at play here. Thank you.
Thanks, Geraldur. I'm giving the next talk. It's the one on Gillespie and using IVUS. Okay. Yeah, go ahead.
Which patients do you screen for? Let's say they have, obviously if they have like a leg ulcer or something like that, but should we be looking more for it? What's the best test?
Yeah, sorry, I should probably have stayed up here, but we do an ultrasound evaluation, obviously, of all of the patients that have ulcers or swelling, and you can tell if you really have difference in the physicity on ultrasound on Doppler or between the left and the right common femoral vein. That by itself will give you a hint if that is not present. We have a fairly low threshold of doing a CT venogram also of the pelvis, and that I think we now understand better what the CT findings are. And then we do venography, and pressure measurements have not been very reliable. The cardiologists have a very nice way of actually increasing the venous return by having the patient's bike on a bicycle, and we have had one example where we could actually demonstrate a significant pressure increase or pressure difference increase with exercise in a patient actually with retroperitoneal fibrosis and compression, not May-Thurner, but so that's more physiological, and we haven't done anything about that, but ultrasound, then CT, or even MRI.
Thanks, Geraldur. In this talk, I'm going to go through a little bit of my thought process in using intravascular ultrasound to optimize venous stents. Single plane venography has been used extensively for looking at iliac vein obstruction, pelvic vein obstruction. But unfortunately, hemodynamic testing of venous stenoses is really not possible due to the low pressures, and we really haven't worked it out quite well to look at gradients, etc. Single planar venography is easy in diagnosing iliac vein obstruction when you see things like this collateral formation, etc. Or, as Dr. Bjornsson showed you, this kind of widening and pancaking. Sorry for the left room over there. But I could try and use the mouse, I guess. But sometimes you can't really tell. So if you really hate IVUS and you want to increase your diagnostic accuracy, of venography, at least use multiplanar venography. This is data taken, as Dr. Bjornson showed you, from the Raju paper. Here's 0 degrees, 45 degrees, 60 degrees, and you can come up with some kind of idea that there is some kind of narrowing there, but still, it's still pretty much of a swag. Certainly, we use multiplanar venography to increase the accuracy of diagnosing how we do with treatment. Here again, 0, 45, and 60 degrees. You see collaterals having been formed around the obstruction, et cetera. And then here's post-stenting, collateral formation is gone. And again, at multiplanar venography, it looks good. So I wouldn't stand here and argue with you that you couldn't use multiplanar venography instead of IVUS. I just think it's more radiation, it's harder to do, and IVUS is an alternative, which is pretty easy. It's certainly superior to single planar venography. I have a setup like this where I put a V-fusion onto the table so I can do a heads up and look right here as my volcano, as opposed to using a standalone machine. This is the old Jomat. I got to get rid of that slide, but the new machine you can see out at the volcano booth, which is pretty easy to do for portable IVUS, and I use it for bedside filters, et cetera, which is all off-label. But intravascular ultrasonography is not hard to learn. I mean, you learn cross-sectional anatomy, you learn how to do B-mode ultrasonography, and so it's a combination of the two. Shows intraluminal defects. This is the probe here in the center, and the outlining of the intraluminal defects, and the dark circles are the outside of the vein. And then you can also see within the field of visualization, you can see adjoining structures like the overriding aorta. So I would say to use it more generously, then you get more experience with it, and then you can start judging what is significant and what is not. I can also tell you that in general, veins are what we call anisotropic. They're not round. They vary according to the patient's hydration status. That's another problem. So you've got to be careful how you interpret that data. Here you can see typical inferior vena cava. Here you can see some compression by an overlying aorta. And here you can see what looks to be interluminal thrombus and an occluded vein. So you start to get, again, used to what IVUS looks like. And here you can see collapsed vein around the catheter, and here you can see partially recanalized vein. And lastly, one of the other ways I use it, other than to determine size, which I think I'm going to go through here in a minute, is to pre and post assess. And that is, I don't really look at whether the lumen's occluded because I know that, but it's good to document it. And then here's with the stent in place, and you've got your luminal gains back. So let's see if these videos work. I am a huge anti-acronym user, so I hate the words May-Thurner. Everybody says, does that patient have May-Thurner? I have no idea what you're talking about. I don't know what May-Thurner is. I know what thrombotic iliac vein obstruction is. I know what non-thrombotic iliac vein obstruction is. Everything what Geraldo was talking about is non-thrombotic iliac vein obstruction. That's why Naglin and Raju called it NIVL, non-thrombotic iliac vein lesion. Mostly what I do is thrombotic. These people have histories of DVTs, ipsilateral to a swollen leg or severe venous claudication. So again, I don't think we have it well worked out who we should be doing any of this in, but you try and find those patients with venous claudication, pain on ambulation or after ambulation, that is disabling, and in thrombotic patients, I think you have a lower risk-benefit ratio or a higher risk, lower risk-benefit ratio. So it's the benefits outweigh the risks as opposed to non-thrombotics. I really worry about people over-treating these non-thrombotic patients without much data. So let's look at the difference between venography and IVUS for some lesions here. So here is a venogram. Does that patient have a problem or do they not? You tell me. I can't tell. This is single planar venography. Could be that this is non-opacified blood coming in from the other leg that you really can't tell, or I could do multiplanar venography, but I choose just to use IVUS. So here's the IVUS of the same thing. Apologize for the herky-jerky, but this is all done low tech on an iPhone. So here you run up the IVUS, and you know, I'm no expert at non-thrombotic, but I didn't see a lesion there. I look hard for intraluminal defects, all that kind of thing, and I just say, well, you're not getting a stent from me, because I'm just not aggressive with non-thrombotic patients. So I did go back and use some of the measurements of trying to look for 50% reduction, area reduction, and I'm still trying to find out who needs stents in non-thrombotic cases. Here is the Volcano is an easy way to measure it. You simply push freeze, and then you hit measure, and if that doesn't work, you can put dots around it and measure it quickly. You can do the same thing with the other commercially available Boston Scientific things. I just use Volcano because it's easy and it's not fragile. Here you can see that was the pre-obstruction area. This is the area of obstruction, sorry. This is the area of obstruction. And again, it's compressed a little bit, but how much is physiologic and how much and anatomic and how much is a real problem? So again, I apologize, but I'm not very aggressive with non-thrombotics. I have a lot more experience with chronic thrombotic patients because I just don't feel like I can hurt them. And I know that if I can open them up, they'll improve. So here's a case of chronic thrombotic lesion. They kind of range in severity. This is a case, I believe he's got a vena cava filter in place, which has caused him to have vena cava narrowing here. You can see it pretty easily on cavography. Here is a static of that, so you can really see it a little bit easier. This is a patient who I previously stented and came back with recurrent disease. There's a mag-up of it. You can see it's a trapeze filter. He's been stented with the in situ fenestration type technique. And here's the IVUS of the same thing. Come on. Still a rookie with all these videos. But again, it's pretty easy. Just do an IVUS pullback. You can see the trapezoidal nature of the cava with the trapeze filter in. And as you pull back, boom, there's the big stenosis. It looks obviously worse on IVUS than it does on cavography to me, but pretty easy to see. You might also say that there's intraluminal thrombus that you can see here, and I believe that that's what also occurs in these. It's not intimal hyperplasia, it's just chronic thrombus. You can use the measurement techniques, as I explained to you before, comparing that to the stenosed area, and then again, here's using a kissing balloon technique to try and combat that. We really have terrible balloon technology right now for dilation. I use XXL balloons made by Boston Sci, but they're really not very robust, and they break pretty easily, and then you can have problems with windsocking and all kinds of things. So we need better technology with regard to large volume balloons. And still, you know, I crush a lot of filters with angioplasty and stenting, but that trapeze filter is a hard one to do. Okay, so here's another chronic iliocaval to diagnose now. I should have just had these on auto, I guess now. All right, there we go. There you can see another filter, conical shaped filter. I think it's probably a Cook. Here you can see a static image of the stenosis. Really a little bit hard to tell on cavography. Here you can see what the stenting pattern was. I don't believe I did that, but that was, I felt, somewhat unfortunate, and that we'll address that in another talk about bifurcation stenting. Here's the IVUS of the same area now. And you'll, oh goodness, okay. You just, thanks. Thought it was magic, I wasn't doing it, but. So you can see the pullback's easy, there's the tip of the filter, and then boom, the big stenosis before the stents. Remember Neglin and Raju's paper that talks about understenting? Now you can see why. It's an area of thrombus formation, chronic thrombus formation there. Just hit it, play it one more time. Thank you. So pull back, normal, retrohepatic cava, keep coming back. There you can see the stenosis, then even some in-stent restenosis there, right there. So I personally think that's a lot more diagnostic than the single planar cavogram. All right. Here's a case of acute. Yep, thanks. So this is pretty easy. This is like an initial stage, catheters in, you're doing thrombolysis. Just for giggles, shoot a cavogram to see what kind of thrombus burden's like. Just for purposes, because I don't think my movie worked out in this case. It didn't work out in this case, thanks. So this is after 24 hours of thrombolysis. It uncovered this lesion, and actually I continued it for another 48 hours, but now you got to start worrying about thrombolytic dose and should I continue, et cetera. It's not cleaning up. I felt it was chronic, and it didn't do more. Here it looks on IVUS, very clearly, huge luminal obstruction. And here is the post stenting venogram, yep. Which looks much improved. And then the last IVUS, again, you can size it for your stents, et cetera. But that was the area of compression now resolved. So personally, again, I don't think it's absolutely mandatory. I know that some people run into cost issues with their value analysis people in their hospital. I personally think it's worth it. I think it's more sensitive. I think it's faster as a diagnostic tool than multiplanar venography, and I think you will be more accurate in what you do and treat. I'll show you some other ones about treating bifurcation lesions in the next lecture, but that's my cavography versus IVUS talk. Thanks. Any questions? Yeah. I'm pretty much a wall stent guy, you know. For me, it's about luminal gains. And I just don't think that placing a 12 millimeter stent in pretty much any vein is accurate. I think that one of the biggest uses I use IVUS for is for determining luminal area. Even though it's anisotropic or whatever, I think it's better determined by IVUS than it is by any other method. And I think you'll tend to undersize if you use venography alone, and I think you'll more accurately size if you use IVUS. And they're not, every external iliac vein is not a 12 or 14, and every common isn't a 16, 18. Sometimes you get post-stenotic dilatation or pre-stenotic dilatation in the venous system. And you can decide what to do. Nobody knows really what to do, but I tend to co-opt the vein stent with the wall. Any other questions, quick? All right. So our next presenter is Dr. Thorpe. Patty's going to talk to us about IVUS imaging in thrombolysis.
Thank you very much, Dr. Gillespie. Thank you, everyone, for coming today. And we'll have a debate about stents in the stenting in the IVC and iliac here as a discussion, which I hope Dr. Gillespie will join with us then. This is a talk that I have prepared for 2 weeks ago when we presented at the European Venous Forum. So I wanted to share that with you here. The analysis of IVUS images in my practice has been going on for more than 10 years. We actually started using IVUS at the University of Iowa in 2002. And when I count back for the last few years, when I've been at Arizona Heart, there have been 171 consecutive patients. And you can see the female-male division, the average age that we treat, because we treat mostly post-thrombotic problems as well. And on average, people get at least 2 IVUS sessions when they come in for their baseline studies, and then when we follow them up from the thrombolytic therapy or the stenting procedure. So, and when you get out the IVUS and you do the examinations, you put it in a minimum of 2 times, well, possibly minimum of 1 time, but very often you're making more than 1 pass. So you accumulate a lot of images to see and learn from. So we find that the management decisions that can be optimized with using IVUS include the placement of stents, whether or not to continue lytic therapy, particularly in a case that has acute or subacute that you've used one of the mechanical thrombectomy devices in. And it's very important for me in my practice to follow patients with stents, and when they're symptomatic and they're told that their veins are patent, their stents are patent, but they're still symptomatic, we examine them with IVUS. And that shows us the intimal hyperplasia that is not picked up on the percutaneous ultrasound. So in terms of treating the May Thurner, I agree with everything that David said, and that if you don't have IVUS and you must rely on venography, there are ways to optimize it, and you learn over the years what to look for. It's like the Eskimos have 11 kinds of snow, and we have maybe 1, because they live in the snow and they recognize minor modifications. And when you are used to looking at these images, you start to see that it's not quite as dark here, and you come to recognize that that's where the vein is splayed by the compression against the vertebral body with the artery on top. And so the density here is because there's some stasis of flow relative to the width of the channel here. This is narrowed. And you start to learn that these, variations of gray are meaningful. When you look at IVUS in that particular patient, you see how narrow it is. I'm a little different than David, but I didn't ask him whether or not his non-thrombotic patients were symptomatic. We usually only examine people who are symptomatic. We're not looking for May Thurners that are patients that aren't symptomatic. I think when they were doing CCSVI exams, a lot of people were getting left iliac evaluations who had never thought of having a left leg problem, and they did find some lesions, but these are all patients who are complaining of left leg swelling or discomfort or have had tibial DVT, and the thrombotic episode isn't in the iliac, it's distal, when I find that quite often as well. So this is a patient who doesn't look like she's particularly too symptomatic because the legs are fairly symmetrical, although the left leg is slightly larger than the right. But she is a woman who's fairly compensated, but she's had a 3-year history of thrombosis. And in this area, you can see complete thrombosis on the day 1 with this big collateral. And she's symptomatic. She's a young woman, 3 years old. 3 years ago, she got a DVT when she started birth control pills and fell on the ice. It's always a combination of events like that. And so we put lytic therapy in overnight because I didn't get the wire all the way to the cave of the first day, so we lysed it for a day. And, And, you had the same problem yesterday. The lesion is much more apparent the following day. So a lot of that was subacute thrombus, a chronic lesion here, and here's the reflux into the hypogastric, just minimal collateralization. And here's her lesion. I'm sorry, it's going too quickly for me here. Go back. The lesion, you can see it's quite wide and quite narrow. And so that is the appearance of what is the iliac compression in her. Then I also go below that lesion to see what the measurement of the normal iliac vein is, because I like to size the stents keeping in mind the normal size of her vein, where it doesn't appear to be abnormal. And I usually check mostly the ipsilateral side, and then we can stent, and in her we put in 14 millimeter stents. Now, keeping in mind what Dr. Gillespie just said about the 12 millimeter stents, before they made larger stents, we only had 12 millimeter wall stents, and we put in hundreds of them, and they remain patent because a 12 millimeter lumen, even if you open it up to 9 or 10, is a very good conduit if it stays with laminar flow and good inflow and good outflow.
And we're done.
Is that it? I don't think so. So there's another woman I want to show you, a patient who was treated for the most part for sclerotherapy for many years, but it turns out that she did have some subtle edema in her left ankle and left calf. It got worse when she traveled, and one of the pictures on the left is from February, the other one from July, the other one is from February. And she had tibial DVT 2 or 3 times and was documented and treated with Coumadin for a short course. And finally I said, well, really, how much does this leg bother you? And she says, yeah, it gets really heavy. And I said, well, you never said that before. And it turns out that we said, well, let's look at you to see if you have a May Thurner. Well, the first time I did her venogram, I thought, that doesn't look too bad. And we did IVUS, and I wasn't that impressed. So I said, I just don't think we should put a stent in you because I'm not sure that's enough to account for this issue. And yet, when we did the venogram and IVUS the second time she came in after a subsequent episode of popliteal DVT, I looked and I learned that it's quite tight on the edge. So it's like half of the May Thurner that we normally see in total compressions. And what I put out there for everyone is that who knows what this looks like when she stands up. It could be a lot worse. We've never stood someone up with the IVUS probe pulling back. So in this case, and what I also had learned from Dr. Raju and Neglin, because they stented some patients that I didn't stent at Iowa, the patients went for a second opinion, and patients would tell me, well, I feel a lot better. My leg is just normalized now, and I had been very conservative in telling them I just didn't think it was justified. So there are things that we continue to learn, no matter how many times we've done these procedures, because we just don't know all the ins and outs of this, like Dr. Bjornson said. So in terms of thrombectomy results, I think IVUS is really important in this regard. A lot of people using mechanical thrombectomies to treat a patient like this with a phlegmasia. This woman did have a carcinoma, but she presented with a very bad leg, and we used a trellis procedure. You can see the lymphedema. This is not totally acute. It's been coming on for over a month, and after the very initial venogram shows a tremendous amount of thrombosis in all levels, multi-segmental thrombosis all the way to the cava. And you can see when you get a little contrast in through here how much there is a lot of acute thrombus, probably on some chronic stuff up north. And we use a trellis and to debulk and see how good it can get. And actually, I don't think that looks too bad myself. I thought, well, that's pretty much a lot better. It got better in the femoral than it did in the iliac. So then we look with IVUS. And the IVUS shows a tremendous amount of residual thrombus, but what the trellis does is that it creates a lot of crevasses. So if you actually were able to draw around all of these little areas, ins and outs, and you would see there's a much greater surface area for contact with lytic therapy. And that's why I think when you do an overnight lytic infusion with a catheter on selected patients, you really have a much accelerated result with your thrombolytic therapy compared to just putting the catheter in de novo or not using it at all. I think the result of what I call trellis plus is better than just trellis alone. Now, this is a patient in whom we also used trellis. He presented with two really bad legs. This is the, you can see how red and inflamed that is and how bad his thrombosis is here in the iliacs on both sides. And we used what I call party trellis. It looks like a party balloons there, but we used bilateral trellis at the same time, and we actually even went through the occluded cable filter without any difficulty at that level, and we got a moderately good result. It doesn't look too bad. I mean, there's some flow. The cable filter was still occluded. There's some obvious junky stuff here still, but again, when you look with IVUS, you see a clot burden that's bigger than you see with venography, because the venogram will track the contrast through all of these little, little inlets too, and it looks better on a venogram than it does with IVUS. Overnight thrombolytic therapy, just with a very low dose on this gentleman who had several risk factors. It was almost pure saline with a little bit of TPA, produced an impressive result, and he did very well long term, actually. So, restenosis and stents. I've been impressed with how much better you can see it. This patient was told at her outside ultrasound exam that her stents were widely patent, but she was very symptomatic. Her right leg was really bothering her, and every time she developed venous hypertension from the stent issue, she developed almost a pelvic congestion syndrome as well, with bloating, discomfort, heaviness. And so we brought her in and did a venogram, and I've outlined in red where we saw the stenosis on the venogram itself. And with the venogram shows widely patent stents, I agree. And you think, well, what's the big deal? How could that cause this much venous hypertension? But when you calculate the narrowing of the channel, when you look at the IVUS, you can measure the area and see that after an angioplasty, you've augmented the transluminal area through the flow considerably. And so the pressure goes up when you narrow the lumen. The resistance goes up, the pressure goes up. You reduce that, the pressure goes down, and the patient symptoms actually dissipate. And I've been impressed with all the patients in whom I've seen this restenosis phenomenon. I actually said in the beginning, I'm not sure I'm doing anything. Angioplasty really is the only thing I have. We don't have a way to go in and ream this out. So I'll do the angioplasty, and every single time their symptoms go away. On occasion, they will come back and you redo it again. But in this particular patient, this is the only time that we've done her only twice. Now I want to just go into a little bit of discussion about thrombus, and we saw this slide yesterday, but we used to think that mostly you have a normal vein and a thrombosis from the outside in, but what I've come to learn in dealing with thrombus is that it's actually the clot forms in the center of the lumen and gets larger and actually expands outward. But when you use lytic therapy, even though you don't get a perfect vein, if you augment the lumen by even 1 millimeter or 2, you increase the flow logarithmically because the flow is proportional to the 4th power of the diameter. And so keeping that in mind, you don't have to have a perfect looking vein to get a good result. All you have to do is restore this vein to what it's supposed to do, is carry flow from the foot back to the heart. So when you see an image like this showing a clot in formation in the femoral vein, you can imagine how, of course, that would be a lethal pulmonary embolus if it embolized. But we've just caught this at a point in time where it hasn't completely filled the vein. If we come back maybe a few hours later, we won't see hardly any evidence of the vein. It may be just a complete blank from here to there. So you can see the whole thrombus will augment without anticoagulation and just keep growing until it expands out to and expands the vein itself. So that's acute thrombus in formation. Well, looking at these types of patients with IVUS has shown us the following patterns. We see always this ring sign. Here is another example of the ring sign. It's similar to what we see on the venogram in that there's this channel that's close to the periphery. And it could be called a halo sign or a ring sign, but invariably, even when you're lysing thrombus inside stents, you're seeing this ring sign. So physiologically, patients are actually transmitting probably their own urokines and TPA from the vessel wall. And then, of course, when we go in to do lytic agent, we're only augmenting the autolytic process. Some patients have almost none, and some patients have more. But again, this ring sign is evident in every single patient. So I started to see that when thrombus dissolves and you get this ring sign, actually what lytic therapy does, either autolytic process or when we augment it with catheters, we're breaking it up and causing little holes and channels and getting rid of whatever is dissolvable, and what is more organized, of course, stays as a residual remnant of the process, some of which we think is probably collagen by the time we get to it, and it's very old. But there's always a mixture of thrombus with all this organized fibroblast tissue. So the difference in my thinking has changed just based on what we've seen with IVUS. And here, again, are fenestrations. If you look at arterial specimens from the coronary arteries of people who have had autopsies following, their demise with coronary disease, you will see that in the coronary arteries, this exact same pattern of fenestrations within the thrombus. And that's why sometimes we can get a wire to go through these channels, even though the venogram or arteriogram shows absolutely no flow. So again, fenestrations here. This is probably part of the process of recanalization, which isn't very well described anywhere in terms of the stratification of a little recanalization or a lot. Here you can see that we could depict this to be multiple channels or one single channel with a real irregular configuration. Anyway, recanalization on a venogram looks fairly decent until you look with the IVUS and you see that there's a lot of residual thrombus in what looks like a pretty good venogram. But I have always said, and I'll stay with this, that a ratty-looking vein that works well is better than a stented vein that doesn't work at all. So I really try to get the femoral veins so that you can get flow that just go through it, and we concentrate placement of our stents in the larger veins up above. And I'm just demonstrating here, when you pull down in that femoral vein that we just saw on the venogram, that you can see lots of areas where there is residual filling deep. That's a pretty normal looking area, but you see down in the thigh, there's a lot of residual thrombus here that hasn't dissolved, and oftentimes you can pick up the perception of two different channels. It may or may not look like that on the venogram. The important thing in this particular patient was the flow went right through. There was no stasis of flow. So you don't have to make the vein look perfect, especially after 3 years. And it just has to work well and provide good inflow into the stent system. So I think with that, I'll stop, and thank you very much.
Great. What are you going to do for the next debate thing?
We're just going to show an interesting case.
I have one question, Patty. That was all Boston Scientific IVUS, is that correct?
Yeah, I use the Eagle Eye.
Yeah.
You use the 8 French?
Oh, that's Eagle Eye
That's
Volcano.
a 6 French Volcano.
Yeah, the difference, just a little IVUS education. Again, I don't think there's any difference well, I'll be specific. If you use Boston Scientific, it supposedly has better image quality, more crispness, but it is a single crystal that rotates. You have to have a housing unit and put it up on the patient and then run the catheter back and forth. I personally have had problems with that because we're imaging over longer areas or around bends, and if that catheter kinks or whatever, it will break in that rotational housing unit, and I've gone through more catheters that way, which is expensive. So the Volcano catheter is 12 crystals that are static. It doesn't move, it doesn't rotate. It's a simple catheter back and forth. The image quality I find just as good. Now, what Dr. Thorpe just showed you is another subtlety of that, and that is she's gone to using a smaller catheter, which in general will give you a much larger field of view in a big vein, and you can ring that down so that it's image, you can see the walls. That's one of the challenges. And the other thing you can do with that is you get chromaflow, because that chromaflow that you saw there is not available in any other catheter other than the Eagle Eye that I know.
Right.
Not that you need it, but just it's another tool that we don't know how to use right
It's
now.
pretty. We don't have, histology. The
Right.
histology is designed for plaque, and the cardiologists use it to typify coronary plaque. It doesn't seem to do anything in terms of identifying what's going on in a chronically thrombosed vein, but we've asked them to try to start working on software that'll identify nuances between ages of thrombus, which you could characterize with pixel density. However, the Eagle Eye is a monorail system. It goes over an 014 wire, so it requires an exchange. You can use a 190 wire, and because it's monorail. The interventional radiologists aren't used to using monorail, but it's pretty easy to get the hang of it. And the 8 French is an 035 system. So you've got an 035 wire in place, so it makes it easier, but I prefer the resolution that you see here. It's cleaner with the 8 French. But the 8 French has been adapted for all the aortic work. So it's kind of a natural thing for vascular surgeons to use the 035 system.
It's just nice, especially for kind of a teaching forum, to show people using different techniques, different tools. So,
but to me, the 8 French is real grainy, so I really like the sharpness of this one. Well, I'm sorry that, I'm technically deficient in being able to download a live case that we had sent to me we did a live case for ICON this year, and I was going to share that with you. But in lieu of that, I'm going to just share an interesting case that demonstrates some of the values of IVUS too. So this is a 28-year-old woman who, again, same scenario, took birth control pills. She is A positive blood type as well, if you're interested in that dimension. Left iliofemoral DVT in May 2012. She had a TPA and a single Zilver stent placed May 29th. The first images of her diagnostic studies that were done elsewhere show that she had some thrombus here in her femoral. Her iliac was totally occluded with some acute thrombus here. You can't really see where it's supposed to go up there, but they did some thrombectomy TPA overnight, and you can start to see the outline, the outline of the May Thurner here and the residual thrombus kind of starting to resolve. And again, when they got rid of more of the thrombus, you can see the collateral, the narrowing here of the channel. And they placed a short 4 centimeter, 12 or to 14 millimeter, I can't remember which, Zilver stent right here. And I think in retrospect, ignoring this narrowing in the distal common and external was probably not a good idea. The stent seemed to be up high enough in the initial placement, but they had the residual narrowing. And that's a judgment call that you learn. We've learned to stent more than less when it comes to irregular inflow to keep the good flow coming through the stent. But she did, in fact, rethrombose within 3 days. Part of it may have been that residual narrowing. Part of it may have been the fact that they pulled the sheath out of the popliteal and sent her out on Lovenox instead of Coumadin, which I think is a little risky in patients who have had a lot of manipulation. But over the course of the summer, she started complaining of a throbbing pain and ache in her thigh and calf. And it got better with rest. So in July and September of 2012, she had repeated venograms to check for a problem, and all of these were interpreted as patent common iliac vein. She underwent ultrasounds on these dates, a CT scan, an MRI on these dates, and a venogram on all these dates. So in the course of 6 months, this woman had multiple studies to try to determine the reason why her leg just kept bothering her. They kept telling her that nothing was wrong, everything looked okay. Well, you can imagine her frustration, and she continues to feel this throbbing pain behind her knee and continued to take anticoagulation and wear a stocking. But interestingly enough, in December, she went to get some dental work, and her Coumadin was held. And at one point, her left leg got worse, but by the time she came to see me in late January of 2013, now that should be 2013, she actually wasn't complaining so much of this throbbing pain. So it was a little confusing to me because she was feeling pretty good by the time she got there, and I thought, well, you know, why? Maybe you shouldn't have come all this way if your leg's feeling better. But what we did was we went in, and this is again the original venogram from before, and I'll show you that when we looked with IVUS, that you pull from the cava, pulling down, and you'll start to see the stent. Here's the stent, but there's a lot of thrombus in that stent, which has narrowed the lumen. And it's a short stent, so at least half of it has 50% more stenosis with what it looked like to be residual thrombus that probably occurred right when she thrombosed the first time and they went in and tried to open her up again. So it's enough to cause an increase in pressure in her leg, but is that the whole story? You can see the still images, there's quite a bit of thrombus there. So the solution for me at this point was to place a stent, and we placed a wall stent. And if you, I could show you the pictures of the CT, but the CT showed that the silver stent had been compressed and flattened out. It was pretty pancaked up here in the common iliac. And we see this with smart stents, and this is a nitinol stent as well. They seem, in some people, they seem to get pretty compressed at the iliac level. The nitinol just doesn't stay open as widely as the wall stent does. The wall stent, when you look on CT, has a nice round configuration long term. Well, here is the IVUS. This is a little bit of a valve you can see there, and an IVUS pulling back once the stent was in place, and which shows a good resolution of the initial problem. I think we're going upwards. Seem to be stopping there, waiting to see something here. Here we are coming into the revised vein here, I believe. And there, it looks pretty good. So that first problem is still a little bit narrowed there, but the first problem seems to be resolved. And there was some degree of improvement when we took the popliteal sheath out. But my protocol is always to look with IVUS, with ultrasound. Every person stays, I take the sheath out with the patient fully anticoagulated, I leave them at bed rest, tell them not to get up and walk, Foley stays in for another day, and then we leave them with an ultrasound to exclude an AV fistula before they leave the ward. And about twice a year we'll find an AV fistula, or sometimes they have an occult hematoma, and 24 hours after the sheath is out, the patient walks and starts saying that she has this throbbing pain. Now, you know she's anticoagulated. I'm thinking, oh my goodness. Now we repeat the ultrasound, and we find, this is a three-dimensional CT that doesn't show too well in this area. There is indeed a fistula. Well, I went back and looked at every single image that came from the other hospital, and I looked at mine, and I'm thinking, wait, who started this fistula? Of course, it's academic. She had multiple punctures in this area, and this is, in fact, a fistula with what I didn't appreciate at the time. It looked like just a really short little fistula here, but now in retrospect, I can tell that this is a vessel leading down, and it's a geniculate artery. So at this point, what are your options? And we can actually use the little markers here, the little white voting things. You can turn them on. The power, I think, power is on the bottom. If you turn them on, we'll vote here. The options are the following. Here we are. There's a little bit of stenosis in the vein at this point, which we also would repair. But here is the IVUS going into the artery, going through the little fistula tract and into the vein. Now, the options are to either put in a stent, excuse me, here I'll show you IVUS coming from the vein. You see the constant flow in the vein, pulling back into the fistula. You can see the artery pulsating, and there's the artery. So this fistula was very small, very small. So on your voting clickers, there's several options, and we discussed this amongst all of us at the hospital. Would you put in a covered stent in the artery, A? B, would you embolize the fistula tract? Or C, would you leave it alone and just see if it closes off? Let's vote and see what you say. Lots of surgeons put in AV fistulas to keep venous stents open. So, and in fact in Brazil, that's quite common, isn't it, Dr. Rossi? Do we have the results?
The devices might not be turned on.
Are your devices turned on? Tell us again where the on-off. It's really neat when you do it here. Are they on? Okay, so A would be a covered stent in the popliteal artery. 2 would be embolization of the tract with a coil or gel foam maybe. And 3 would be do nothing, or C. You don't have one, do you?
No, it's okay. No, I'll tell you what I do.
What would you do?
I put a covered stent in the artery.
Okay. Okay, so A, covered stent in the artery, B, embolization, and C, nothing. Well, okay, that's an interesting breakdown. So what I'll tell you what we elected to do after discussing amongst the surgeons and myself. Well, I put in a Viabond stent. And we put in a stent, and this is an IVUS of the stent. I want to show you how important it is probably to look at Viabond stents with IVUS because you can see them beautifully, and you want to make sure that a Viabond stent is completely expanded. So you don't oversize them. You try to size them very carefully to the vessel so that they don't crinkle and get redundant in the midst of it. See, it was a little bit crinkled, and so after a balloon angioplasty, that opened up and assumed the size of the vessel wall. So in conclusion, it looked like the iliac stent was compromised. So we fixed that part. Then perhaps in retrospect, the throbbing pain was an AV fistula, and she had a partial steal. She was developing claudication in her calf when she walked because it was stealing into the vein so much. So the throbbing pain goes along with the increased pressure in her venous system. Well, after we put in the stent in the popliteal artery, we sent her home. And she went back across the country and seemed to do better for a while. And just anecdotally, I'll tell you that she came back last month, and she still had swelling above the knee. It was hurting again. The AV fistula was definitely there on duplex. And when we did the venogram, we could see that the fistula was apparent. There was still a stenosis in this vein, so that needed to be corrected. And let me go into this. I want to show you that the fistula came from the geniculate artery. Oh, that's the vein that we angioplastied here, so you can see that we improved the vein. There was some residual thrombus there. But here's the fistula, and it feeds from the geniculate artery. It's an injection here. Let me see if I can figure this out. There's the fistula. And when here's the stenosis, also there was some edge stenosis on the Viabond at 6 months, which we had to dilate too. and that's the residual stenosis that was dilated. So that part got fixed. But this is where I wanted to show you. When you're injecting the artery here, the fistula filled off the geniculate, but it actually filled retrograde through these branches. So here's the popliteal artery, the anterior tibial, peroneal, posterior tibial, and you can see branches coming back up from the geniculate that feed off of these tibial arteries back up to the geniculate artery. So in retrospect, if I had embolized it right here from the very get-go, it would have solved the problem, which I didn't appreciate 6 months ago. So we were left with the option of trying to embolize small branches that feed the geniculate arteries. One in particular came off the anterior tibial right here and connected directly to this area. So we were able to get back up into one of these branches here that fed directly into this neck. And in the end, we were able to put coils right at this point. And we thought about surgical ligation. When I presented this case, I said, before I start embolizing these vessels, does anyone want to just, do an open surgery and just ligate this branch? And no one wanted to do that. So we ended up doing some embolization of the branches from the posterior tibial and the anterior tibial. And the bottom line is that even though I'm not sure we did a complete job of that because it was very difficult.
You think it was traumatic AVF versus AVM? Because once you start, the patient had a history of some type of trauma, you think?
There was trauma in her life when she was 5 years old. So, but that seems so remote, and she hadn't had any positive ultrasounds prior to the initial DVT. So I think it was iatrogenic trauma from popliteal
I think you just need to make
punctures.
sure of that first.
Yeah. So the bottom line, it was a very difficult procedure. IVUS did help us with all that, and the patient's doing very well, despite the fact that I didn't think we really embolized everything adequately. Her symptoms are gone, so we dissipated it enough for her to feel normal, and the flow now is mainly not into the vein, but into the artery.
In trauma cases, we find that embolization is a good option, but you generally have missile and history and everything else, and if you find it off of a tibial vessel or a geniculate vessel, then pretty more straightforward as opposed to stenting the major artery.
Well, the initial fear of embolization was that if it was such a short little track,
Right.
that it would, if it went backwards into the artery, then you'd have a worse condition. It wouldn't bother me if a small coil went to the pulmonary bed through the vein, but I certainly didn't want it to embolize to a foot of a otherwise normal person.
No, we wouldn't do
Yeah.
it to a big vessel, major vessel.
Yeah. So, well, anyway, question?
When she came to you after having the silver stent placed, the IVUS showed a fairly large thrombus burden. You mentioned stenting her with the wall stent, you redid the IVUS. I didn't see any residual thrombus. You didn't talk about any debulking. What happened with that?
When her thrombus and the thrombotic episode, I suppose I was thinking it mostly came from last June and July. It could have come from December, but there was so much flow through there. If you put lytic therapy through there, most of it's just going to be flowing past what small amount of thrombus was there. So it's you don't get very much bang for your buck. You could have dissolved it, but I just resolved to put a stent there and correct the situation because the stent itself was narrowed. So even debulking it didn't correct the entire problem. If you could have seen the CT, you would have seen the stent was more like that instead of like that.
So what do you think happens to that residual thrombus once you re-stent?
Yeah, just push it aside. We pushed it aside. You can still see a little bit of it. It's like a sandwich, 2 stents and a little bit of density between them. And we don't tend to acutely stent acute thrombus. I always will resolve it. But once it's chronic and it's not going to dissolve with thrombolytic therapy, then we just push it aside in a native vessel or in this situation. Because I'm going to show cases later this afternoon about stents that are occluded. How do you treat occluded venous stents?
And chronic thrombus doesn't tend to squeeze back through the interstices once you restent.
No, not in wall stents. Okay, lots of good questions. Okay, thank you. What's next?
Debate?
Okay, good. You be part of the debate? Yeah.
No, I don't know who is.
Well, I have a couple of slides. I think Dr. Bjornson's here, but I think you have things to contribute to.
Sure.
I have a couple of slides to put up for the debate talk. It's just a setup so that we can consider the issues. I think Dr. Gillespie spoke. Harold, do you want to come up here? Dr. Gillespie spoke about it earlier in terms of the multiple planar imaging you have when you turn your image intensifier to certain angles, and you can see better. But do you have the slides for that particular time? There we go. So the debate issue is, and it depends, I think, whether or not you have the ultrasound. When I first started doing IVUS, I had to borrow it from the cardiology section. And the politics in a lot of hospitals prohibit you going over to cardiology and borrowing the IVUS, or they're using it all the time, and there's only one in the hospital. And so the argument for me in the interventional lab was, well, why do we need to buy such an expensive piece of equipment just for you? So you have to work through the politics of your hospital. But in my practice now, when I've used this and it's available to me every case that I need it, then I've come to appreciate how much I didn't know. It's like a blind spot in your brain. If you don't know that you don't know it, then you're not hurting. But once you see the images that you could obtain with it compared to the venogram, and I know I missed a lot of May Thurners in the past by not having IVUS, yeah, it makes you think about it differently. So the issue is venography good enough and I don't need IVUS, or is IVUS a tool that can optimize venous interventions and I really should try to use it more in my office, or not in my office, actually they're using it in the office, but in the cath lab. So I'm going to show you 3 images and you can decide. Oh, we didn't vote on the last time. You get them all turned on? Did they turn on? Let's say A or B. A would be this is a lesion to stent and you don't have IVUS and you're just relying on the venography. Is this a May Thurner or iliac compression that you would stent or not stent based on the image? Say A, you would treat it, B, you would not treat it. Surely there are more than 12 people here. Is everybody voting? Okay, so just a few more people would not stent it than would stent it. Okay, let's go to the next lesion. Okay, this is another lesion. Patient, venogram and a patient. This patient now at this point is supine. So the left is the left. You don't see the right. So A, you would think this might be something you would treat, or B, you wouldn't treat it.
Can I ask you something?
Yes.
Oh, just for the debate. These are all patients that are doing a venogram because they are symptomatic, right?
Actually, not in every case. These lesions may be found incidentally when you're treating something else. Okay, so I know that does determine your action.
Because symptomatic or non-symptomatic patients would change my
Exactly, and
my mind.
in this particular case, the patient was asymptomatic, but we're getting that most people, based on the venogram, would treat the lesion. So you're right. That is an important variable that you have to consider whether or not you're going to treat there's a thing in radiology, they always tell you, don't treat the radiology, you don't treat the x-ray, you treat the patient. Okay, now this patient. This is a 52-year-old woman with tibial DVT. A, you would treat this lesion, or B, you would not treat it? Okay, so most of the people here have already learned from Dr. Gillespie and all of us up here that this is a lesion that looks like a compression. What was C? Nothing at all? And this is, in fact, that one case that I showed you where I didn't treat her initially, but then I did treat her. Well, these are the images. I'm going to show you the IVUS that goes with this image. There's the narrowing, 2x9 measurements. The narrowing on this is like what we call a partial May-Thurner, or I don't know, we'll have to think of a good name for this, but it's what I call a half May-Thurner. But stenting provided her significant relief from swelling and discomfort. And this case, the patient was asymptomatic. We were working on the right side because he had had a closure failure and developed a thrombus and problem in his right common iliac vein secondary to an angioceal. So we were on the right side, we did the venocavogram, and there is his lesion, and yet he had never had any problems with his left leg that he knew of. So there are a lot of patients who have a significant compression, but again, you didn't see any collaterals there, so his physiology was normal. So with that, let's start the debate. And I'm biased now, but I run into a lot of people who say, I don't need IVUS. What do you think, Haraldur?
So I'm in a similar situation as you were before, Patty, that we have 5 procedural rooms and we do not have a dedicated IVUS machine. We do borrow from the cardiologist, and I have used it probably 10 times for this problem. I liked the comment from our Brazilian friend, Dr. Ossi. I do not treat these lesions unless they are symptomatic. If the patients, if you find them because you are looking for something else, you're treating something else, I will not treat them, and I think we all agree on that. I have used ultrasound because I've been unclear about the anatomy, and the cases that Pat demonstrate that dilemma. So there have been occasions where the patient complains of symptoms in typically the left leg. The venogram demonstrates no collaterals and a very questionable narrowing either at the internal iliac vein crossover or at the common iliac artery, the internal iliac artery crossover or the common iliac artery crossover. So those are the main circumstances. I think if you have done this for a long time, you get a better understanding of how the venogram looks. I think and that is a benefit for us, the radiologists, just because we have done it so long. But having said that, I do not dismiss the fact that intravascular ultrasound can be helpful. So I think really this depends on what you are comfortable with and what you have at your service.
Well, Patty, I might as well take the easy shot, the pro-IVUS standpoint. So my fear in venous stenting is that it's going to go the way of prophylactic IVC filters. I'm a filter nihilist. I think they're incredibly overused. I think patients should be anticoagulated. So here we are taking off with a new technique to treat people. We think it's safe and effective, but we have not had really any robust trials of anything, not even in thrombotic patients, let alone non-thrombotic patients who we think might have a problem. So I think that a reason to use IVUS unequivocally is that if you use, and actually IVUS is more critical than multiplanar venography even. If you can't see it and define it, you shouldn't be putting stents in patients. I would even tell you that in non-thrombotic patients, until we really know what we're doing, I would encourage you to be conservative. If you want to get into this business, get into treating thrombotic patients who have iliac vein obstruction, okay, and have symptoms. Those patients you can't hurt because they're already maimed. But if we start generalizing this and start putting a bunch of stents in people who we think might have a problem because it's quick, fast, and easy, and then we do it in the office, the whole thing is going to get majorly criticized. So I would tell you, use IVUS. And if you see something that is unequivocal in a patient who has unequivocal symptoms, I'm for it. But short of that, I'm not for it.
Can I give how we do in Brazil? Because we have cost problems and insurance company approval problems, so we have to deal with all of that. I'll start from the beginning because I'll start everything if the patient is symptomatic. So if the patient has no symptoms, and edema is considered a symptom and a sign, right? So we start from the...
I would say that's arguable.
Yeah,
Edema is multifactorial,
yeah. Well,
can happen from numerous things, and I would say there's no data.
Yeah. If you think that this edema is coming from a patient with a left leg edema and you didn't find any other systemic or anything else that could explain that edema.
And it's a specific pattern from hip to foot. It's got
Okay.
to involve the entire thigh kind of thing.
Okay, so what we do is this patient starts with an ultrasound, and in my service, we consider a ultrasound if you study from the feet to the cava. So it never ends in your groin, the ultrasound. So we need any information coming from the groin to the cava. Even if the patient is big, they should give us something that we should, that it does explain the disease or it doesn't. After that, if we decide to go on because we don't have explanation for everything, we do a venogram. We start with a venogram, and the venogram has two possible answers. So you do have a thrombotic patient, or you do have a non-thrombotic patient. A non-thrombotic patient leads us to three possible channels. He definitely has an stenosis. He does not have an stenosis, or we are in doubt about that. What we do a Valsalva maneuver, and we measure the pressures. If that doesn't lead us to an answer to that patient, then we ask for an ultrasound study at the same time.
The only thing I would say about that is there's no data on pressures.
Yeah.
There's zero data. I mean, is a caval to iliac vein gradient of 2 significant? Of 3 significant? I mean, you have no idea. I mean, there's no data. That's the problem. Is that right now we're just based on structural things. And here's the worst case scenario, and this has happened to me, is that you take inexperienced people at putting stents in people and think it's really easy, because it is. It's very easy to deliver a stent.
Yeah.
The problem is that they migrate very easily, especially in non-diseased cavas and undersized veins. So now take an inexperienced person placing a stent without perfect imaging because they are not using IVUS, okay, and they undersize that stent. They treat a patient who doesn't have extensive disease, and all of a sudden that iliac vein stent is in the left atrium or in the right atrium. Now what? Now, I've seen it time and again. I know people trying to do same thing with placing same stents in the SVC, you know? I mean, this is not a place for inexperience and bad imaging. And so, again, I think while it doesn't happen often, because right now you're in the early adopters and the experienced people, treating the worst of the worst, when you generalize this to people who have no experience and they start putting stents in people who I consider these non-thrombotics more difficult because the stents are not as engaged, okay? And you start having problems, we're all gonna be having problems.
Thank you. I really agree with what David's saying because we've already received several patients in whom I think it's natural for cardiologists who are dealing with, in their training, with small vessels. When they start working in the periphery, particularly in the veins, their thinking is usually smaller vessels. It's hard for them to imagine that a 12, 14 millimeter vessel is there, particularly if there's a stenosis below and you're not fully expanding your lesion, your real lesion, with contrast. So the only way to evaluate it accurately is with IVUS. And maybe with or without the Valsalva maneuvers to see if it's a normal vein that will expand with increased pressure.
Do you do Valsalva maneuver
No.
with IVUS?
No.
Because I remember, Patty,
I don't see it.
by the time we were, remember selecting the patients for the Venous stent implants, and they had a venogram with and without Valsalva, and we saw that they could enlarge those veins by 50 and 60%. So we had to decide
normal
what size.
veins will. That's true.
Yeah.
Normal veins
So
will.
sometimes you're doing an IVUS and you think that there is something there, but also if you do a Valsalva, that IVUS image can change too, right?
Yeah, it will, definitely. And I just want to finish this train of thought. I think for medical legal reasons, people who are doing IVUS, experienced or inexperienced, particularly if you're new, you better cover your bottom with IVUS imaging, because I personally, over a period of 30 years, have stented several people in whom I had the venogram. I was really sure there was a lesion there based on even the venogram. No IVUS, they were stented, and their edema didn't go away. Now you don't really have an image of the lesion, you've got a stent in a person, and there's no improvement. One was a young girl who her edema just persisted, and I had no explanation because I was sure there was a May-Thurner compression as well, but I did not have IVUS, which I wish I had. Well, she went up to sent her to Tom Rook at the Mayo Clinic, and he diagnosed her with a condition called lymphedema precox, which is a failure to develop enough lymphatics, and it can be unilateral. So her leg was a combination probably of a May-Thurner and a lymphedema issue, but she didn't get better because we treated only part of the problem. The other lady was a very unhappy lady who had lymphedema, probably based on the fact that she had donated her kidney, her left kidney, to her husband, who subsequently divorced her. So she was unhappy with me because after I put the stent in, the stent worked great, but she went to get life insurance, and this was in the early 2000s, and they refused her life insurance. So not only did she not have her kidney, she had a stent that wasn't seeming to correct her problem, although she had thrombus, and we had seen that too, but we had no IVUS. And on the basis of all of her unhappiness, she filed a lawsuit. Well, in the end, the lawsuit was dropped because there was really no damage that we had caused. I mean, it was complicated, as you can see, but the whole thing was dropped. But, oh, I wish I had had an IVUS. The venogram was pretty good, but if we had had intravascular ultrasound, it would have just really been in my favor. So and then there's another case we just recently received, just like the one he talked about, where very first time stenting experience went awry because the physician put in an 8 mm stent in an iliac vein. Because
you
to
one
his
other-
eye, it looks small.
Another thing that comes to mind is, I don't know if how people are doing with their radiation safety and Alera in the cath lab. I do know that in New York State they've lowered the overall radiation dosage and limits. When you start doing chronic thrombotic cases, they are long radiation cases. You start using magnification, your radiation goes up immensely. And it's not necessarily, if you do a long case, different than a fenestrated aortic case. So IVUS cuts down on that. And then you put into that angulation, multiplanar venography, which is what we're trying to compare it to. And you know that once you angle your
Tube,
II tube away from you at an LAO position, you're getting full face, head and neck radiation unless you've got good time distance shielding. So, I mean, nobody really makes too much of an argument about that, but you can clearly see that multiplanar venography presents more of a challenge for radiation safety than IVUS does.
Well, I would just like to say that I do agree with what Dave says about stenting the non-thrombosed veins. That should not be common practice until we actually understand what we are dealing with. And the veins are capacitors. So if you have a patient that's dehydrated, the veins are small. And you do not, I don't think we quite understand the physiology of flow in the veins. We do not have a hemodynamic way of evaluating the veins, and many of these patients, or most of them actually, are only symptomatic when they are on their feet, and even only when they are walking. So this is a much more complicated issue than that, and as far as I know, we do not either have criteria for the findings that we have on intravascular ultrasound, as far as I know. So whatever method we use to diagnose these compression symptoms and stenosis or obstructions, I would like to just echo what both of my colleagues here have said, is this is not something we should be doing illy-willy. This is something that needs very careful considerations. I'm not sure that the IVUS is the answer, because the problem is so much more complicated than that, because the hemodynamics of the veins are even more complicated than the hemodynamics of a renal artery. So even though Peter Neglan and Raju have found clinically there is an improvement from stenting these unclear narrowings in the iliac arteries, I don't think we understand quite yet what the answer is. So that's where I'm coming from. We are very conservative when it comes to treating veins that have not thrombosis in them, and in patients with unspecific left, in most cases, symptoms.
And it'll certainly be nice to have some multi-center studies, and I think that's probably an opportunity for the two stent companies that are coming out to do multi-center studies and really get good quality of life improvements, and really have multiple centers, so you're not just looking at the River Oaks kind of experience, you're generalizing it, and you can really see that it's not only safe but also effective with good quality of life indicators.
Having said that, Dr. Gillespie, I think it's important for interventionalists to lobby with the FDA to include IVUS imaging in the evaluation of new stents. I think if the standard is just venography, I don't think that's quite enough, knowing what we know now with IVUS.
I actually did do that with, just recently did that with the Cook group with their trial, and I'm not exactly sure, Joe, where that stands, but I did tell them I wouldn't put in a stent unless I could use IVUS. And maybe that's not why I'm in the trial, but similarly, like with IVUS filters, IVUS guided filters, there is no indication right now. It is off-label. All of that is evolving as we speak. And I think that's all going to change, but it will be interesting to see with the stent trials coming out, whether that is included, Patty. I agree. Joe, can you comment? No?
That will be an option.
Oh, good. Good. But-
And it hopefully will begin within the next couple of months.
Good.
We're at,
So you're going to collect the data. It's not going to be mandated, but it'll be collected, and then you may even be able to see whether or not there were any size associated or complications associated. That'd be good. Yes, sir.
Question?
I want to thank you because, I've never been convinced of anything more than the need for IVUS. Sorry, Dr. Gillespie, we have a huge filter practice.
No, that's okay.
And I honestly think
Everybody does.
the hardest angiographic images to interpret is an iliac vein venogram because you get so much mixing of contrast. Is it non-laminar flow? Is
Mhm.
it thrombus? Is it compression? I can't tell you how many times I've called my partner and said, what do you think? Is this real? And you can do obliques and still just rack your head. And this just seems, I'm never going to convince my hospital to buy me one.
Yeah.
But
Well, actually, you don't have to buy it. You buy the catheters. They bring in the machine usually and let you.
As long as you use a high enough volume of the
Yeah.
catheters, Volcano usually
Yeah.
bring it in. And don't get me wrong about filters. I do use and love an indicated filters. I just think we've just lost control at this point.
Mhm. Well, I agree with David. If a lot of people start trying to put in stents and have mishaps that are really serious, a stent, the woman that I talked about, the stents got caught in her filter. They went in to take out the filter thinking things were ready to, and then they found an iliac stenosis. So they said, okay, let's treat this stenosis. We're not going to take out the filter today because of this stenosis. And luckily, the stents got caught in the filter. But it was still a huge problem. So it's not trivial, and I think a lot of people putting in stents don't ask themselves this question: what's the worst possible thing that can go wrong here? Because if they did, they might not do it that day or without the right equipment.
And the other thing is that most of these guys, they're thinking arterial instead of thinking, venously. So it's quite different.
We have two questions here.
What kind of criteria do you use to consider a lesion obstructed by IVUS in the vein? We know the criteria in the artery. What do you
The non-thrombotic, common iliac, just keep it to that area. For me, there's a very obvious narrowing from anterior to posterior with a lot of wall thickening and some hyperdensity, hyperechoic material indicating it's very chronic. And it'll be wide in the transverse diameter and very narrow in the AP diameter. And then the symptoms of the patient, it goes along with a leg that's abnormal, larger than the right leg. Patient who says, my left shoe has always been tight. So, if they've never thrombosed, they're going to give you that kind of clinical picture of venous hypertension in the left leg. And then I believe that kind of finding on IVUS goes along with that lesion. And then when you stent it, the symptoms do resolve.
I think all those things are fine, but it's never been studied. The largest series is out there is Neglin and Raju, and they report their data, and they say 50% narrowing is what they did, but, never been scientifically studied, really.
The only trouble with that, excuse me, Shriko, is that, the other leg is a normal control on most of these people.
Yeah.
So they've had a lifetime of one side normal and the other side something different. So sometimes these asking for a level 1 data is a well and good, but I think these people are their own controls.
Yeah, I wouldn't say randomized controlled trial, but it needs good, large clinical studies. There's a study out by Melina Kibbe from Northwestern right here in town where she just pulled CT scans and she looked at everybody's narrowing, and it's all over the board.
Mm-hmm.
What she failed to do in that is control for hydration status. So yes, it's all over the board, and their hydration status varies. So really just looking at luminal narrowing in a patient, you have no idea their hydration status or anything else. You just don't know. These days, skilled venous stenters are very conservative, as we're saying. They take patients with the correct symptoms and the correct leg and lots of experience to do it rarely. Sir?
What are your recommendations for the May Turner patients, young females who you stent who will, want to get pregnant in the future?
Oh,
Regarding, pregnancy, possible compression of the stent, does that come up? Because I've had that come up.
sure.
Questions.
I have a topic about that, but I must confess that we were going to then focus on something else, but I'll answer your question with what I know from more than almost 30 years of doing this. I have at least 12, and I'm sure both of these doctors have other patients, but we've had more than a dozen patients whom we stented when they were 17, 18 in high school, and they went on to have normal pregnancies, vaginal deliveries and C-sections based on their own circumstances, multiple pregnancies, never any problems with the stents, never any problems with the pregnancies based on the stents. Now, that being said, they've all been high-risk pregnancies because of their history of DVT, so they've been treated with Lovenox during their pregnancy, and they've all had ultrasounds at the very beginning and after delivery to establish that there's no problem with the stents, but they've all done well. There's only one or two articles in the literature from Hartung in Germany that sort of documents their experience with 9 patients.
So non-thrombotic May Turner that's treated for swelling or pain with the stent, they are on anticoagulation at our institution for 3 months following the stent placement, and after that there is no need for anticoagulation. If they get pregnant, there is no need for anticoagulation in these uncomplicated non-thrombotic May Turners. The question becomes more complicated when you have had thrombosis. Then you have to think about, is there an underlying hypercoagulability status? Is there poor inflow from below? And that becomes more complicated. Do you need to cover them with a heparin product during the pregnancy or not? But as your question was that if they are clean May Turners past the 3 months of anticoagulation, there is no need for.
She's high-risk pregnancy, yeah. I believe that history.
Yeah, I have to admit, I keep all my patients anticoagulated. Again, because I've got this skewed population of doing mostly thrombotics and rarely non-thrombotics.
There's a question over here.
Question, I just want to ask what the panel about how their approach is to patients before they come in for stenting for May Turner. Do you do a full thrombophilia workup? Because I've had 2 patients that I've seen that had no history of DVT, but yet you put stents in, they thrombosed. And in retrospect, when we did the thrombophilia workup, they were positive for factor V light or something. So I was wondering, do you approach it? How would you approach these type of patients? Do you order all these coagulation studies first, or is that necessary?
Well, I just told you tipped you my hand. Again, I'm anticoagulating everybody, and I tell them they take their own risk when they want to come off. And so with that, I don't really try and find it. In fact, my clinical experience has led to a lot of research questions that I just can't answer. I have patients with therapeutic INRs on Coumadin who thrombose. I changed them over to low molecular weight heparin. They seem to do better. So I think there are plenty of undefined hypercoagulable states, it seems to me. And so if you find one that has a hypercoagulable state, that's easy, But usually they'll have a history. It's not that common to have a presentation like you're saying, where they come in totally never having a history of a DVT or anything. You put a stent in, they thrombose. So, and then if you talk to your hematologist, and I would encourage everybody to do all of this stuff kind of in concert with the hematology group. It keeps you honest. It gets them on board. They refer to you. You help them. They'll tell you that they do not, in general, agree with, willy-nilly kind of hypercoagulable testing for people. It's really got to be patient-specific and history that guides you. So they even would have said in all of those patients, don't do the workup, and then after they thrombosed, treat them.
And even people with factor V Leiden aren't consistently anticoagulated
Right.
because they don't think the risk of thrombosis is that high. But if you individualize it, like with Dr. Hunter, it depends on other factors. It's
Right.
not just the factor V issue. It's in concert with everything.
It's just a potentiating factor.
Yeah.
So our take, and I agree with Dr. Gillespie, include the hematologist or the clotting people in all of the discussions or decisions like this. Patients that comes in with clean May-Thurner does not get hypercoagulability workup. A patient that comes in with clear reason for DVT, I believe, like a young woman with on birth control pills, would probably not get hypercoagulability workup. When the patients have no clear reason for the thrombosis, you do thrombolysis or you recanalize an IVC or iliac vein, you need to get your hematologist involved.
In our service in São Paulo, since we almost do 100% of our patients are post-thrombotic venous patients, we have a dedicated hematologist. Her name is Ana Clara, and the only thing she does is the workups and taking care of every hematological aspect of our patients. So she just work with that. The patient, before going to the angio seat, will have to have a consultation and a total workup with her. So it's...
Should we stop with that, Patty?
I
It's
think so,
10:47,
yes.
yeah.
Yeah,
Okay.
Dr. Hunter is going to moderate the next session for us. I've asked him to step in and help and be part of the discussion. So anybody wants to just stand up and stretch their legs? We'll go ahead and continue. Thank you. Thank you. Thanks.
Everybody make sure that you've exercised your calf muscle pump and maintained a good state of hydration. Speaking of which, contrary to what the other panelists said about working up people for thrombophilias, we've been much more aggressive about it at the University of Minnesota, primarily because, like the experience in Brazil, it sounds like we have a person who's very interested from the hematology side in evaluating these patients. And people with birth control pills, people with a variety of sort of contributing factors but not obvious precipitating factors like knee surgery or trauma and whatnot that get DVT, you always have to wonder, why did they get DVT? And I think that that's a very legitimate question, and that's one that we try and answer on every patient who gets it. And the main reason is not so much because we're just curious, but if a person gets a DVT and they have an underlying thrombophilia. Now they've got a thrombophilia and an abnormally altered venous system. And therefore, for the rest of their life, they're at higher risk. And I think that they have to be watched much more carefully, treated prophylactically for any interventions, and potentially even considered for chronic anticoagulation for the rest of their life, which now, for instance, is my condition with factor V Leiden, and having had 4 or 5 recurrent episodes of below-knee DVT, my circulatory system, my venous system on there is disordered so much that, you know, a standard flight to Chicago is enough to sort of precipitate problems if I'm not anticoagulated. So I anticoagulate had been for every flight, but now I'm just chronically on Coumadin. So we're going to start out our late morning session here with Dr. Ossi again from Brazil, who is listed to give us a history talk on venous surgery and stents, but instead I think is going to regale us with a much more fun topic, and that is managing complications. So you can choose your poison at this point.
Well, yeah, this is more complicated, but a lot of fun to deal with this kind of patients. So I'll start this presentation just showing you this slide that has reviewed 1,082 treated patients in 38 different publications, but only, and I'll call this your attention for that we still don't have large publications about what we are doing with these venous patients, and this is why we have this kind of discussion about the IVUS and everything. So only 8 of them had more than 10 patients, so it's a lot more of a personal experience publication than anything with multi-center information. 12 of them showed 0% complications, so they were taken out of this review, but they meant only 5% of all the studied patients. So from the other 95, what we got, is this working? Well, okay, so we had only 9 deaths, intracranial bleeding 0.27%, only 5, pulmonary embolism 12. So these are very low numbers.
You can also use this.
I'm trying to do this, but okay, you did.
You just have to activate it.
Yeah, you
It's a
did.
little hard to activate.
Well, see, you did, and I don't.
There it is.
That's okay.
There it is, on the bottom. It's really hard to follow.
Yeah. Well, okay, so I'll do without it.
Yeah, make it bigger in red or something like that.
Well, that's not a problem. Rethrombosis, 6%. So all we see here is that there are very small numbers for a large number of patients that we reveal. Who's doing that? You're doing that?
He's trying to help you.
Yeah. And all the major numbers are related to minor complications. So this is not, so everybody keeps saying that treating thrombotic patients with lytic therapy and all these devices that we already have here is very risky, and the patients are at risk of death and everything. This is not true. But we do have complications that are important, and the learning curve to do these procedures is important to avoid them. So what is important? I keep saying, and I just said that, it is important to know everything about venous diseases, because what I see in Brazil is that people start doing venous procedures, but they still think what they know about the arterial procedures, and this is very different. It's a very different environment. Everything is different. So you have to change from the arterial thinking to the venous thinking. you do have to know the venous anatomy and physiology, because this is a low pressure system, a low velocity flow. So everything you do that can lead to thrombose if you're still thinking in the arterial way. Of course, knowing all the endovascular techniques to avoid technical problems, and know the patient procedure measurement, because these are patients, especially the post-thrombotic, the chronic patients that are not coming to the angio seat in the morning and going home on the afternoon. These are patients that you are bringing to the angio seat 3, 4, 5 times in a row in this week. So you must be careful that this kind of management will change the outcome of that procedure. Avoid judgment errors. So when you're doing the procedure, you must be thinking that, what am I going to do the next step before doing it, before deciding it? Because this is the moment that you do something wrong, and you can rupture a vein, you can rethrombose everything you did the day before, and lose the entire procedure, 3 days procedure, doing that. Avoid timing errors. So this is the kind of patient that you cannot leave what you decide to do today for tomorrow, because only 3 hours is enough to have an entire recanalized vein thrombosed. So don't wait for tomorrow. Avoid communication errors. You are working with a team that includes ICU, hematologists, clinical doctors, the angio suite guys, everyone. So you must be talking to them all the time. Specifically the Venous team. They have to know everything about that patient. My assistant, we don't go to the angio seat before he comes to me and explain and tell me everything about that patient. I need him to know everything and pass to me what he knows. So we have what we call the general protocol, where we put every possible information about that patient. Then we have a second protocol, which is the procedure protocol, where we will discuss the case, decide what we are going to do, the strategic procedure. So we will follow that every day. Total concentration to the patient and procedure. So that is related to the fact that these patients are coming back to the angio seat for 2, 3, 4, 5 days. And these are patients that will stay in the hospital for 7 days. So we must be focused on this patient and leave everything behind. So if you have a soccer game, if you have a baseball game, just forget it. And total communication, as I said, to the ICU, to the angio seat guys, to the other specialties. So if you have a patient that needs an endocrinologist or a neurologist, they must be in touch with you all the time. About the ICU, so what we did is that we took all the protocols to the ICU doctors, to the ICU nurses, and we sat down with them for hours to discuss everything we do and everything that will be done with those patients, so they understand. Because even having a service that we bring all these patients every day, the ICUs are used to work with all the patients. So the overload of other problems will keep them away from these patients, because if you look those patients during the day, they are just sitting there and have lab controls, and they're just waiting for the next day. So they think they are easy patients, so to speak, but they are not. They're receiving TPA and heparin at the same time, with multiple catheters coming in and out. So they look like they're easy, but they're not. Again. Okay? The angio seat itself. So we have problems with scheduling those patients because they're coming every day. So one day they start at 7 o'clock, but the next day they have a aortic prosthesis coming in. So they will have space for that patient at 7 o'clock in the evening. So you have to schedule these patients for an everyday coming back to the angio suite at the same time, because you need that 24 hours control, angiograms and everything in order to have success rates in your procedures. The transport from the ICU to the angio suite is key. Sometimes you have a hospital that the patient comes from his bed to another bed and then goes to the angio suite, and then they take him off that bed to the table, and then back to another table, back to the ICU. All of these procedures will make the catheter to move from the place that you left that day. So this is important to pay attention. To select and have the right material that you need for that day, because they don't think like you do. They think that you ask for just one set of guide wires and catheters and everything, and this will be enough for the entire procedure. So on the third day, you just find out that something is missing, that you don't have the guide wire that you need, so you have to go before the procedure every day to the angio suite and select and take the material that we will need for that procedure that day. Anesthesia. It's sometimes we do with general, and sometimes we do with just sedation procedures. So, but we ask for anesthesiologists in an everyday basis at the angio suite. So these are the kind of complications that we see during those procedures. The bleeding of your puncture site, your access site is quite normal because we are delivering TPA and we are delivering heparin. So you don't make that thrombfibrin, how do you say that? That closes down the puncture site. And so, so it will bleed like this in every patient. It's not that much, but it will happen. What I want to share with you is that if the ICU is not ready, it's not comfortable, if they don't have your protocol in their minds, they will call you at 3 o'clock in the morning saying that the patient is bleeding to death, and when you get there, what you see is this. So they have to know that this is normal because you have an access and you're having heparin and TPA infusion, so the bleeding will be normal. What we do in these cases just change the size of your access, of your sheath, and this will stop. What they do in some ICUs to cover the bleeding, so the nurses, they don't like that, so what they do is this, and the next day when you come, this is the kind of precipitation you'll find. This is another complication that we have when someone that is not completely trained to do these kind of procedures will try to do. What we see is this huge bleeding intramuscular and everywhere, because they just try to do multiple punctures in order to access the vein. And then they started heparin and TPA. And this is what happened 24 hours later. So we had to take everything out and send the patient to the ICU for many days. And she had neurological damages. And then we had to take her back months later to treat her problem. So this cannot be seen in any patients. Just one shot, one puncture. If you had to do more than that, just live there for 15 days and come back with this patient, because if one of them had hit an artery, or a small artery, or a small vein, this kind of bleeding is what you have in just one day. This is what happens when you didn't talk about these kind of patients in the ICU, and they come to draw blood samples for lab control. So this is the puncture site. And this is what happened because these patients were under heparin and TPA. So you must talk to the nurses and talk to the ICU guys that you need a dedicated access just for labs because they are in a 4 to 6 hours controls every day. This is what can happen. This is a picture from Dr. Patricia that I really enjoy to show to the ICU people, to show them what can happen if you don't pay attention to the protocol. This is something, this is a complication that comes from our friends, the anesthesiologists. So we were doing this case, and we had the patient covered, and we were working down here, but the anesthesiologist decided that he needed blood samples for labs. So he tried to puncture the jugular vein here. What he did was to puncture the carotid artery. And this is what happened to the patient. And we were working here. And then he called us to show, oh, see, we have this small hematoma forming here in the neck, but I don't think it's a problem. This is what happened 24 hours later. And this is bleeding, intracavital bleeding, which can happen when you have a vein rupture. This is an interesting case that we were called to treat a cava obstruction, and they said, well, the problem was this filter that was implanted, and then we did the lysis, and then we returned it here to find out that the filter was implanted in the gonadal vein. So this is how we found that it wasn't in the wrong place. This is a picture. This is a slide from Dr. Tharptooth. Hopefully, and I'm happy to say that I didn't have this kind of complication yet, and I hope I will never have. But this is what she got out of the atrium. This is a very nice picture. Thank you. Yeah, sure, just once. It's not your patient. And this is what happens when people use different types of stents. I'm a wall stent guy too, just like Patricia and Dr. Gillespie. I think that in this area, you have such a lot of pressure coming from the organs down there, so you cannot use any kind of stent here because this is what you have. And the differences between diameters will lead to rethrombosed veins. This is one patient that we did a kissing reconstruction from the inferior vena cava. And then you can see here that we have the narrowing of one of the stents that led to thrombosis. So this is a difference between pressures from the same type of stents. So they're the same stents, but this is how they look like. And you get a rethrombosed side of it. The other one is okay, but we had to put another stent here to compensate pressures and then reopen everything. This is the case of rupture. So you can see that you have this, I don't know the name for that, Dr. Hunter. How would you call this? Because it's the end of one stent and the beginning of other one that have moved out. They were not in a telescopic configuration. So this stent hit the vein wall and ruptured. So we had to put a covered stent here to give a solution for this problem. The other problem is that patient that we receive later, that people are trying to treat the May-Turner syndrome here. But what happened is that, as you can see, the stent is below the artery, so it's not treating anything, and the patient was referred with signs and symptoms of compression. And she said, well, but I already have a stent in, so how come I didn't get better? And we found out that the stent was below the compression site. And another patient that we had that had a central nervous system bleeding because she was a chronic renal failure patient, and we used the same doses that we use for other patients, and she had a epidural bleeding, which is, I think it's not normal. It's not, you don't see that every day. I tried to find that in the literature, but I didn't. So she had an epidural bleeding, and the neurosurgeons had to take her to the OR and just drain this blood, all this blood from her. And the last, I think this is the last image, is that one from that patient that we started to, this is not a complication, it's just complicated to deal, because this patient came to us with inferior vena cava obstruction, and we started to treat her. And what we found is that she had this caval tumor. It doesn't come from outside. It's not renal. It's a primary caval tumor. So we had to stop everything and tell her that instead of a caval obstruction, she had a tumor to be treated, which is not easy. So, in conclusion, I would say that doing these venous procedures seems to be very easy, and they are very friendly, but they can turn into a huge problem if you're not ready to think as a venous procedure, to have the necessary and the proper communication with the guys from ICU, from the angio seat and everything, in order to have the best outcomes that you can get. Thank you.
Stay there for a second. Okay, even though we're a little bit behind, anybody have a quick question they want to throw at him? All right, I have one quick question for you. We had problems with bleeding at the puncture site until we completely eliminated all skin nicks. We never do a skin nick with the knife where we're going to put the sheath. Do you do that also?
No. Sorry. We don't. No. It's just
Okay.
the puncture, and we do try to keep the skin very tight to the access site, so
Right.
we avoid that kind of
Yeah.
bleeding.
And the other thing is that part of our protocol now is for us to put in a PICC line on every one of these complex venous patients instead of having the PICC line service do it, so that we know that it's a single puncture thing.
Yeah.
Okay, so the next talk is going to be back with David Gillespie, who's going to talk about venous stenting above the iliac vein, how far into the IVC. You know, there's arterial stuff on there on that topic that shows that even if you get the stents past the point where they're just about to touch, as soon as they touch, the patency goes down. So I'm hoping you have some exciting stuff to share with us.
Well, thanks very much. I want to thank you, Francisco, for, again, exercising caution to our audience. I think you can hear there, it's a little bit different than the Neglin and Raju experience that says stent anything, never have a problem, anticoagulate everybody, it's all good, to there you saw ruptured a vena cava. I've ruptured a vena cava, I've ruptured an iliac vein, and unless you know how to bail out to a covered stent or do something else, you know, you saw stent migration, that's reality, okay? It may not happen as often as in the arterial system, but it happens, and unless you're ready to deal with it, you shouldn't be doing it. So some of what I've got to say in the early part of this may be kind of redundant, so I'm going to kind of cruise through it. Again, these are chronic venous ulceration. We don't really have a lot of experience either knowing where the role of obstruction and venous stenting fits for chronic venous ulceration, but certainly if we could do anything for these patients, it would be great. $1 billion a year it costs, $4.6 million work days lost, and of course the data from the Strandness lab showed that it's the mixture of reflux and obstruction that is worse for chronic venous insufficiency. We haven't really talked too much about that. Here overall, just showing you that the fallacy of anticoagulating someone and it's all going to be better and my vein's going to open up totally really doesn't happen. About 80% of patients on Coumadin really only have partial recanalization, so obstruction after iliofemoral DVT is real, and that's why the societies, SIR, ACCP, et cetera, think that catheter-directed thrombolysis is warranted. Here's some of the early studies showing you where that venous spur can occur. And I mean, this is not anything new. This is 1998 that we've been talking about it. And then Dr. Mewison, who is here, started talking about his national registry, multi-center study looking for thrombolysis. And in this group, they found that stent placement improved patency overall in the iliofemoral system, but not necessarily so in the femoral popliteal segment. Whole nother area of controversy. I would definitely encourage you, don't even think about stenting the femoral popliteal segment because there's just no data. Abu Rama's data just saying that long-term symptom resolution with iliofemoral DVT is good, better than anticoagulation alone, again, for iliofemoral. So overall, everybody is recommending for the iliofemoral segment, even though we don't have high levels of evidence, we think that it's good, but not necessarily for the femoral popliteal segment. Okay, so we talked earlier about appropriate patient selection. Again, I look for those patients with usually unilateral extremity swelling associated with venous claudication, which is generally characterized as a bursting or swelling or pain sensation after walking, not during walking, usually with a history of DVT. I don't really do treadmill testing, but if you did, they'd have the pain afterwards. We talked about multimodality imaging. You've seen these pictures before, so I'm just going to cruise through them when we talked about the benefits of IVUS, and I mentioned Melina Kibbe's data. This is that uncontrolled look at iliac vein compression using CT scan, really all over the place, but then this study really didn't control for hydration. But thin-cut 3D CT venography is good. I personally find most of my CT scan doctors challenged in doing a really good CT venogram. Part of it has to do with flow, part of it has to do with access. Very hard to access a swollen extremity, so they give up. Very hard to give enough contrast in a patient who has a femoral DVT or something like that. You need about 150 cc's of contrast flowing through that iliac vein really to see it well. So again, we really don't have a good method, and we're still searching for it. And this is Bill Marston's data saying how much compression is significant. We really just don't know. You can even take out all your CT reconstructions and say, well, we don't know. But he did study in his data and found good correlation with high-grade stenosis with 3D CT. This is just his data talking about that. Here's a little bit of data on duplex. My king of duplex is Nikos Labralopoulos, who's at Stony Brook. He really helps us out in trying to define all this stuff. So you can do duplex venography of the common femoral vein. It should look phasic, and it should have respiratory variation and augmentation. And when you have obstruction in the iliofemoral or the iliac vein above it, you generally don't. So it is possible to do it, but the question is how sensitive, how specific is that? Well, here's his examination using duplex, common femoral venous duplex to look for obstruction compared to CT and MR, and really found that the highest degree of comparison is in those patients who have really greater than 80%, not subtle on a CT scan, and then maybe duplex can be helpful in this, but we're still at the really rudimentary stages of defining this. So he's good enough in a thin patient to see the iliac vein on ultrasonography. There you can see the iliac vein as it bends into the pelvis, and there is a point of what he thought was obstruction. And so he was able to measure a femoral venous velocity above and below and come up with some kind of diagnostic criteria for this, and found that this velocity ratio of post-stenotic to pre-stenotic of about 2.5 seemed to correlate highly with a degree of stenosis that would be found on venography and treated. The other thing we really haven't talked about, one of the big challenges, especially in thrombotics, is that, again, very easy to deliver a stent, hard to keep it open, all right? The keys in arterial stenting are similar to that of venous. You need to have excellent inflow, excellent luminal patency, and excellent outflow for the stent to be patent. Here you can see a patient with terrible inflow, terrible outflow at this occluded vena cava filter in a thrombotic patient, and you need to be above and below those places for it to work. And then we talked earlier about appropriate stenting, sizing and dilation. I told you I use IVUS for that. So here's the new part in this talk for you today. We really haven't talked too much about it, but how do you treat the bifurcation? I mean, how do you deal with that? Do you just stent right across it? Do you go right up to it, but not really, even though the disease is generally right at the bifurcation? We know that the weakest point of any stent is in the ends of the stent. So do we need new stent design to say that we can put the stent eccentrically and not into the cava so that it doesn't matter? There's no answers to any of these things. Everybody will just tell you their bias. I personally went from the thought that the most strength is in the middle of the stent, and therefore you needed to center that over the lesion, wherever that lesion is. That leads you to stent across the contralateral side, and when you have bilateral disease, you need to get through it. The way that Neglin and Raju did it was this fenestrated technique. In general, you don't need a colapinto needle or anything else so sophisticated to get through it. It just takes patience. You can get through it with standard catheter and wire techniques, and then really take your time to upsize it. The Boston Scientific people are still amazed that this can happen because, as you know, it's kind of one braided stent, and it does stay open over time. But it does lead to a messed up stent. You can see that even though it's across it, it really never expands. It's kind of messing up both sides, and then once you fenestrate from one side, the other side's jailed, and then Rusty Hoffman at Stanford will go back and do bilateral, fenestrations in order to keep it open. So fenestrated technique, a lot of work, long run for a short slide, you might say in baseball, but we need better techniques to deal with this bifurcation. So people have talked about doing kissing stent technique. Neglin and Raju at least took their large series and compared that fenestrated technique to kissing stent technique. They certainly showed that understenting doesn't work when you understent the patient's thrombose anyways. And they did show in bilateral cases that patients who had kissing stent technique did better. And so that's the only study. And here you can see a case where I understented it because I was scared to do the fenestrated technique early on, and he went on to thrombose. So we need something different. I don't think that it's really, this is just, again, me speaking. We don't have much data as to how much is too much and how little is too little. I have had patients who did not have their stent across the lesion fail, and I've had to extend them into the cava. It would be nice to have some kind of device that was fenestrated in the middle and didn't obstruct flow to the other side. That's another way to do it, but nobody really has been able to do it. So we took our last 200 iliocable stents, 65 patients, and we looked at what was the effect of crossing the iliocable confluence to the contralateral undiseased side. Here's 50 patients that we did it out of our total of 65. They're all thrombotic. And only 9 patients received bilateral stents on presentations. So of that 65 patients, 200 stents, we chose 41 patients who had obstruction of the common iliac veins on one side and nothing on the other side, okay, to get a consistent population. 1/3 were male, 2/3 were female. Median age was 48, but ranged from 15 to 80. thrombotic in 95%, I told you, non-thrombotic in 4.9%. About a third, acute, chronic, and acute on chronic, okay? And up to almost half of them involving cable thrombosis. I told you that perioperatively I use warfarin therapy, even intraoperatively I'll anticoagulate them more with heparin, so I'm pretty aggressive with anticoagulation. That leads to all the problems that Francisco told you are bad because the patients are going to bleed. So here's a case, thrombotic case. That's kind of what it looked like. We stented them with standard techniques and did pre and post venography and pre and post IVUS. Here's my wall stent sizes. You can see they run all the way to 24, and that's all based off of IVUS. So I'm a pretty aggressive, large stent guy because I believe that luminal gains matter. I don't believe that we get intimal hyperplasia in this, although there's not much data out there. I just heard one from Dave, I remember his last name, but at University of Michigan, who talked about biopsying this stuff, and so we're starting to look at what causes rethrombosis, okay? And here's our overall patency. You can see that this is very similar to Neglin and Raju in the thrombotic population. Our primary patency rate about 60%, primary assisted patency rate about 70%, and you can get in there early enough, you can get your secondary patency rate up to 80 to 90%. Although you can see overall, like everybody else criticizes your life table analysis, you know, I don't have that many patients that are out to 5 years yet. So with all of that, only 4 patients suffered a contralateral iliac vein thrombosis when they didn't have disease. 4 out of 41, okay? And of those 4 patients, all 3 of those patients were totally non-compliant. So when we talk about who do we use all of these stenting techniques and everything, I choose patients who, again, I'm going to anticoagulate them because they're thrombotic. So don't choose patients who are drug addicts, alcoholics, have psychological problems like, you know, that can't be compliant with their medications, because that is what I did. Those 3 patients were, what's wrong?
Joe's out.
Yeah. So anyways, yeah, they can't be compliant, and that's going to affect the overall patency rate. So of that, 1 in 41 patients who was compliant with therapy ended up with a new contralateral iliac vein thrombosis by crossing the contralateral iliac vein. So again, and with that, you can still get secondary patency rate in those people to bump that up to over 90%. So to date, there's no consensus whether to stent across the thrombosed common iliac vein into the cava or completely across into the vena cava. This data suggests that crossing the iliocaval confluence is a viable and reasonable technique to be employed in the treatment of iliofemoral DVT with a very small percentage, but real, you know, incidence of contralateral thrombosis, even in anticoagulated patients. And I think we still need more data to kind of figure all this out. Where are we going? Do we anticoagulate them? Do we use kissing stent technique? Do we need a different technique? And with that, this is just anticoagulation post-op, but with that, I'll stop.
Thank you. Really good data. Any quick questions? Yes.
Nope, I use the cava. That's why you saw those 24 millimeter stents being used. So again, there's no reason, there's no data. I kind of actually took it from Neglin and Raju's experience that putting the stent juxtaposed to the wall was better than just having it hang in the wall as far as thrombotic rates go. Again, there's not a lot of data with that. This is some data to show what is the risk overall, but I size it to the cava and I align it and oppose it to the walls, and then I'll taper it down. Now, early on, I would use something like 14, 16, 18 and use 3 different size stents. In talking with other venous stentors about this, we've kind of just come around to say, well, you know, if you size it to the largest one and you just put in a 90, it'll auto taper a Boston Sci. You can cut down your stent cost that way, but you got to plasty it up to the bona fide size of what the vein is.
Good question, though, because if you sized it more to the iliac, then you'd have plenty of room in the cava for the other side to flow past it. Very good question. Good thing to think about in the future. Thanks, David.
Okay, thanks.
All right, so next we get Haraldur Bjarnason coming back to us from the Mayo Clinic to talk about venous stenting below the inguinal ligament, the target that we never go to.
So, as has been mentioned before, that the most important part when you're doing iliac vein recanalization, and for that matter, inferior vena cava recanalization, is to assure that you have adequate inflow and outflow. On the arterial side, we have traditionally not stented across the joints. We do actually place the COVID stents across the popliteal artery, but traditionally for the common femoral artery we have not been stenting, and that's because we are worried that metal fatigue, kinking, and intimal hyperplasia may become a significant deterrent to patency in this area. Now, most of that data actually comes from animal studies. Just briefly, this is a very uncomplicated iliac vein recanalization. I do most of my recanalizations from the jugular vein. I always check that the right side is normal if it is left-sided pathology. We then go through the chronically occluded but slightly recanalized in most instances iliac venous system, and then we come down to the common femoral vein, and you can see that this common femoral vein is not normal. I want to point out the great saphenous vein and the femoral vein, and you note that there is discrepancy in the size. And everybody agrees that that this has experience with these procedures, that we should treat this segment also. To go with my first statement, to secure adequate inflow. And so that's what we do here. We place stent all the way down to the first branch that feeds the inflow, which in this case is the great saphenous vein. And not beyond that, and there is really no need, because there doesn't seem to be any disease beyond that in this case. Now, this is what we fear, and this is what we typically would see in the superficial femoral artery, where the stents are subject to severe movement, torquing, and telescoping. Now, if you look at lateral images of an iliac vein stent that extends into the common femoral vein, this is probably down to the profound femoral vein ostium, you could see that the bend is actually not that significant. When you flex the hip joint, it goes over a very long segment. It's not like you get an acute bend. It is distributed over a long segment of the vein. So, and there is no kink. So this wall stent here, at least, seems to have very smooth transition from straight to 90-degree bend. So what about this case here? Can you leave this common femoral vein unstented? You can see that there are segments of thrombus within, and in my judgment, this should be stented. We have no fear of stenting this, as we did here on your left side. Well, what about this patient, where we actually did a combined recanalization of the iliac vein and surgical and venectomy with subsequent stent placement? The patient then comes back with a very severe narrowing of the common femoral vein and also of the profound femoral vein, and that is really the only inflow except for those circumflex femoral veins here. We elected to stent the common femoral vein down to the confluence area where it appeared somewhat open, but still have the very severe narrowing of the major inflow vessel, and this was subsequently stented, and you can see on this slide here that and this is actually a venogram with the balloon higher up, that this is widely open. And this is a follow-up CT scan just demonstrating that the stent actually stays well open. And you can actually also see that there is inflow from the greater saphenous vein through this side of the stent, but don't rely on that. This is another patient. This is a 50-year male patient that had a right heart catheterization a year or two earlier, then developed a leg swelling and wound on his right leg, and was left with this short occlusion or subocclusion of the common femoral vein. This is also something that we would feel very comfortable about stenting, as we did in this case. Placed a wall stent down to the lowest or the most proximal inflow vessel and up into the normal external iliac vein, and this subsequently, though slowly, healed. This is a 41-year-old female patient with a history of recurrent lower extremity deep vein thrombosis and severe post-thrombotic syndrome. We tried to come from the jugular vein, and as occasionally happens, you cannot find a nibbon or a opening into the left occluded iliac vein. We tried punctures, as you can see here. We have some contrast sitting in the soft tissues. We tried to puncture and cannulate from below. We resorted to do a ascending venogram, which I occasionally do to better understand the anatomy and also the distribution of the post-thrombotic changes in the distal veins. And you could see that there is actually a complete or almost complete occlusion here. If you paid attention to the dates here, you can see that this was done in February. We aborted at that time. Got the patient back in October of the same year. And this time I punctured the common femoral vein again, or the femoral vein actually, was able to get a wire across up to the iliac veins, and then snare the wire and come from above. I really like to work from above, because in this narrow area here, this is very narrow and difficult to manipulate. I like to be from above to be able to more precisely place stents and dilate. And in this case, you have clearly stented across a completely occluded common femoral vein and up into the inferior vena cava as spoken for. Now, so what do we know about how well stents do that extend below the inguinal ligament? And again, Dr. Neglan and Dr. Raju have come to our help with that. They looked at this in this paper from 2008. They collected all the patients that they had stented up to that time and split them into groups of patients that had stents placed below the inguinal ligament, and they used an arbitrary anatomic mark to judge that. They found that if they took the entire group of patients that they stented the iliac veins, including thrombotic and non-thrombotic, there was actually a significant difference. There was a lower patency rate in patients that did have stents extending below the inguinal ligament. If they looked at only thrombotic obstructions, they found that there was still a significant difference. So the patients with thrombotic or post-thrombotic changes or post-thrombotic obstruction, if the stent extended below the inguinal ligament, there was a lower patency rate. So not significantly, but not by much. Now they looked at also non-occlusive and occlusive obstructions and found that there was no significant difference if you placed stents below the ligament in a non-obstructed segment as compared to a placement If you had patients with non-obstructed lesion, there was no difference in infrainguinal ligament or above. And the same thing was for a obstructed segment. If the vein was completely obstructed, it really didn't matter if the stent was below or above. The difference came, though, in that there was clearly a difference in occlusive and non-occlusive segments. So it didn't matter if the vein was occluded, if the stent extended below the ligament or did not, but the difference was really between the obstruction and non-obstruction. So they included that they had no stent fractures across the linguinal ligament or erosion of the vessel. And their conclusion from this paper was that it is really the etiology that matters when it comes to patency, and if there is an occlusion or not an occlusion. So if you look at this number here, secondary patency rate was 100% in the patients that had non-thrombotic obstructions. So if the patient had never had thrombotic episode in that segment, there was 100% patency. If you had a non-occlusive thrombotic obstruction, then 91% secondary patency, and thrombotic occlusion, 77. So the conclusion, and there is a long way to get to the conclusion is that really it is the etiology, and if the segment is occluded or non-occluded, or probably thrombotic or non-thrombotic, that matters. It doesn't really matter if you extend your stent below the inguinal ligament. What matters is what I just said. Now, finally, just to touch on something that Dr. Gillespie spoke of, this is a 50-year-old male patient with a 1.5 long episodes of lower extremity infrainguinal ligament thrombosis. He presents with very severe calf venous claudication symptoms and has this partially recanalized popliteal and femoral vein. So what do you do, or do you have anything to offer a patient with this situation? This is a venogram. You can see that there's an occlusion of the popliteal vein. There is some recanalization. We punctured the posterior tibial vein by the ankle. We get quite easily through the popliteal vein and the femoral vein, and we dilate this with a 10 mm balloon, and we are left with a open but not widely open segment, and this patient had actually significant improvement in his venous claudication symptoms. I would not advocate that you do this on a routine basis. Stents have been shown to do poorly in this area from the venous registry, which Dr. Gillespie just alluded to from Dr. Musen. But in patients that are very active, have very significant lifestyle limiting venous claudication, this can be a solution if they have good inflow into the popliteal area and good outflow higher up. So my conclusion is, and this is what has been said before, secure adequate inflow and outflow, stenting across the common femoral vein, even the profunda femoral vein, if you need that in order to be able to get good inflow, is completely safe. Any management of the femoral vein on the popliteal vein is still unclear, and I would not advocate to do that on a regular basis. Thank you.
That's a great place to kind of make that division between sticking in the sort of the common femoral area and below that, rather than just sort of lumping everything from infrainguinal. So that was really good data, a nice presentation. Anyone have any questions for Helder?
Yes.
I'd like to ask you how you would handle a case where it's post-thrombotic and the occlusion allows the iliac vein going to the common femoral vein, the occlusion of the proximal portion of the femoral vein, with disease in the profundus. So let's say you're able to get through all that and you've got your guide wire into the femoral vein. My question is, do you stent across the profundus?
So if I have a short segment of profunda obstruction with a good profunda vein below that, I would do that. I will tell you though that you cannot always predict what you're going to find when you come down to the common femoral vein. And I have had at least a handful of patients where I actually say, I remove my catheter because I don't believe that I have enough inflow to keep the stent open. So I think you're better off bailing out, saying that you're not going to be able to help the patient and rather waiting. And I also experienced, and I have nothing to support this with, that it takes 2 to 3 years for these acute thrombi to remodel, and you can still see these patients back in a year or two with an ultrasound and see if you have now a better inflow area into the common femoral vein, and then make it feasible for you to stent.
Do you think you can judge the inflow with ultrasound, or do we really have to go back to doing like we did in Minnesota for a long time, doing venograms on these people to really see where the inflow is coming from and going to?
That's a very good question, and you saw actually I did an ascending venogram on that one patient. If you are in doubt, you do an ascending venogram, or you puncture the femoral vein just to see what's going on. I rely a lot on ultrasound. You can see the images very well. You see the inflow from the profunda, even the greatest saphenous vein. So I rely significantly on the ultrasound findings, but I do ascending venograms also.
Yeah, we're doing more now than we ever did 10 years ago. All right. Yeah, go ahead.
Just to say that our point of control there is not the inguinal ligament, but the common femoral vein that goes below the ligament. So what we want is to ensure the inflow, and the common femoral below the ligament is where you have the saphenous vein, the circumflex, the profunda. So what we look at before starting a procedure is to find out how the common femoral vein is at that point. So if we have to stent to that portion to ensure the inflow coming from the circumflex, from the saphenous vein, and from the profunda femoral vein, we will do that.
Yeah, and Harold, there's slides showing that you don't get kinking when you flex to 90 degrees. We're fabulous. I love that kind of stuff. Get rid of all the mythology at least. Okay, next talk by Patty, monitoring and treating intimal hyperplasia. David doesn't think intimal hyperplasia exists in stents. What are you going to tell us differently?
Well, we set a patient up many years ago, and I've showed that doesn't kink. It's just counterintuitive because everyone's sitting there with a kink in their groin, but the stents going across the femoral head are perfectly straight. It just doesn't make sense. I want to start with one other thing. Most of the time, bigger is better, and I think that there's a study that's never been done anywhere that if you looked at everybody who was 100 years old, I suspect that their carotid arteries and their coronary arteries are bigger than people who don't live that long in most cases. If you could look at enough patients, you'd see a pattern. So we know that patients who start getting intimal hyperplasia, sometimes it's not necessarily just the size, but we know that plaque starts forming in people's arteries in their 20s. So if they start with smaller arteries and they develop atherosclerotic disease, they're going to have less of a lumen to fill up before they become symptomatic. So the same thing starts to, we think about the venous side. So it's clear that if we could put in bigger stents to a certain point, that may be an advantage. But as I've said, since we started, we put in our first iliofemoral stents, iliac and caval stents, in 1993. So it's been 20 years now. And the stents in those patients that we started stenting in 1993 are still open. 94, 95, we have proof of that. And those were 12 millimeter stents because that was the largest stents we had then. So we know that good laminar flow in that size of a stent that doesn't develop intimal hyperplasia is a good solution, long-term outcome. So just putting in larger stents is not necessarily the answer either. And the data is not at all evident yet that up to 24 or 20 is necessary if a 14 millimeter stent will suffice. We know there's a lot more pain associated with larger stents as well. And the original Gianturco data in the cava showed that much pressure on the cava from stainless steel stents instituted a whole lot of intimal hyperplasia. And the Gianturco stents in the early data from Dr. Gianturco himself showed that there's a lot of failure of those stents because of intimal hyperplasia. So what we've done is we've monitored our cases over the years, and I developed a system whereby we looked at a venous index and we did velocities. So before, when you start, you get an ultrasound that shows no flow because it's totally occluded. When you open it up, then you get a velocity that gives you a comparison, almost like an ABI. And you can use the normal leg as a control. Well, this is a case of a 17-year-old young man who had a normal right leg and came in with total occlusion of his distal cava and a thrombotic occlusion of his left lower extremity. You can see he only has one kidney. We think he perhaps had a very early thrombosis of the cava. So he was transferred from Lincoln with this acute DVT, and he was then stented effectively in 1997. So we followed him all these years. He was a young man then, and in 2001, he came back to see us, and his left leg was a little bit swollen, and he was developing some hyperpigmentation in his left lower extremity. And you could see that he was getting a little bit of this blotchiness. And he came back to see me in 2007. And in 2001, we didn't do anything. We just looked and saw that it looked pretty good. In 2007, we investigated with venography, and we could see some narrowing on the ultrasound. And interestingly enough, you have a focal stenosis, you will get, just like in an artery, an elevation of velocity. But if you get circumferential intimal hyperplasia for very much of a distance in a venous stent in the iliac, it actually slows the velocity. So you're kind of in no man's land unless you have some point of reference. The point of reference would be the baseline study you did when you finished stenting them. So if you're not keeping a good record of the sequential ultrasounds, then you don't really have a good point of reference. The other variables, of course, are the hydration state, of course, and then the technologist who's doing the study. So it's not a very good way to monitor for intimal hyperplasia. It's just what we've had until this point. But you can see that his left leg from behind was some dependent discoloration, some hyperpigmentation, particularly lower down on the calf. And then with the venogram, we saw that in the caval portion of the stents, there was a very curious, high, very focal lesion, very tight, just in one little spot. And it turned out to be right where two stents, I believe, were overlapping, and that seems to be a pattern that we see with venous stents. And then there was another lesion. Now, this is a very tight lesion in the external iliac, and you can see that it's, I believe, just above the femoral head, right at this point. And we've seen that when stents overlap right at the level of the inguinal ligament or right near that area, that there's probably some riding up and down in the body of the stents. Somehow that's a focal area for intimal hyperplasia that I've seen in multiple patients, and the rest of it looked pretty good. Now there's some intimal hyperplasia right along here, but this is definitely
Use the mouse maybe so you get it on both screens.
exaggerate. Okay.
Nice
Oops.
big red mouse there.
There, the big red mouse. Okay, here you see, there's but you see a little bit of narrowing here, lumen, so intimal hyperplasia there. So distal to that, this is so sensitive. There we go back. Distal to that, we see the characteristic loss of phasic flow indicating a proximal obstruction. The obstruction doesn't have to be 100% to give you loss of phasicity. That was a pretty tight lesion. Now the IVUS shows that within the stent you have just a residual lumen that's very small, and all this, well, we don't know the characteristic of that, do we? And I'm going to show you some of what we found. But this is the stent, again, the ring sign, so there's a little bit of flow out here. And the hyperechoic density of whatever is in there. Now, is that thrombus? From one time when he was very compliant with Coumadin, but this looks to me like just a dense material that's not characteristic of anything acute, that's for sure. Here's another view of it where the lumen's just a little bit bigger above the tight spot. Well, what we did is we used the Silverhawk and tried to extirpate some of the specimens and get them out and send them to pathology. And I believe in that initial go around in 2007, the report was like very unhelpful. It didn't tell us that it was anything specific. So here it is, an image of after you use the Silverhawk. You can see where you've taken bites out of the inside of the vessel. And we've used cutting balloon in this situation to try to expand the lumen. So we don't have just don't have the best tools. You want to just go in there with like a cutting blade and just take it around and shave out all that stuff. But after the manipulation, you could see we distorted the stent a little bit as well. And there's some residual stuff because those cutting balloons and any of the devices, the atherectomy devices, will only reach so far. So even if you bend the lumen. So we did our best with that. We come back, and that was the 2007. And that was after we treated it with balloons. So we got some improvement. He still had some collaterals. Actually, he went out and he did pretty well. This was the lesion in the iliac. It looked much improved after the atherectomy and after the balloon angioplasty. So 2007, he went home and his symptoms subsided. He did really well. And he came back in 2011. And he had some additional swelling in his leg. He lives in Illinois, by the way. And he came back to see us again, and this is what we found. The area in the iliac looked pretty good. There really wasn't much issue there. The flow was good enough. But you can see the telltale collaterals here, and you're going up here, and this is the lesion that had developed again. Because we were only angioplastied it before, we weren't able to adequately atherectomize anything. Well, this time I got a little bit more aggressive. This is the lesion at a more, a better view of the lesion. And this is the ultrasound, showing again that hyperechoic density material. We did extract some of the material from here, again with an atherectomy device. This is below the lesion. See how good it looks. And just at this focal area, there was this density. It was a very focal lesion. Well, here's the atherectomy device, angled, trying to take out bits and pieces of this area. You can see the top of the stent here, so we're right about here with our imaging. And this is the material we took out. It was kind of a soft, gushy material that extracted. We got quite a bit of it out, sent it to the pathologist who examined it all and sent us back some slides. And the interesting thing is we saw the smooth muscle proliferation, but what he also saw was what he interpreted as characteristic of atherosclerotic plaque, which was so curious because then we said, no, it's not from an artery. I said, are you sure it's not from an artery? I said, no, it's from a vein. So we kind of presented this to a bunch of people and talked to them, and the anatomist at Arizona Heart, he looked at all this and he said, he looked at the images again, and he said, you know, I think that there probably was a congenital lesion there, maybe a congenital abnormality in the cava, and there's totipotential cells there, and the intimal hyperplasia is just a hypertrophy of some cells that still have the potential to become either arterial venous depending on their location. I don't know if David wants to comment on that because nobody really knows, but it's curious that the pathologist, not knowing the origin of this, thought it was reminiscent of atherosclerotic plaque. So what are we going to do? Our atherectomy catheters only do so much. So this is what I did. I I thought, what can we do to expand this that might last? And what I did is I took a balloon expandable stent made of stainless steel, the VisiPro stent, which has a very low profile. And we placed it there, and you can barely tell that there's an additional stent in this area. It really successfully opens the lumen very nicely in a straight shot. I wouldn't recommend that we put a balloon expandable stent in the venous system below the arteries, below the inguinal ligament, below the iliac artery, but in a straight shot, I have found it extremely successful with good long-term results, and you can see how much improvement we get. No collaterals, and now this was in 2011, and this is the VisiPro dimension. They go up to 10 millimeters and 12 millimeters. They come in these odd lengths of 57 and 37, but it's been a very good solution for this patient. Here is a 3D reconstruction of his stent system. He has no problems ever with his right leg, mind you. Even though this stent goes all the way up on the left, the right leg is totally normal, never even any issues. You can see a single kidney. And this again is the result in the iliac after 4 years, so that we did repeat the angioplasty just to touch it up. You can see where the stents though are crossing over here. So you have to be careful where these stents overlap. And again, when we looked at this from 2007 to 2011, still some distortion in the iliac stent itself, and I can't quite explain it. It was when you angioplasty these stents super hard, sometimes, you start distorting the metal, but it still has a good lumen. Good legs, resolved his symptoms, and he invited me to his wedding in May, and he's now 29, 30 years old. So here we have more than almost 17 years of follow-up on this young man. Not quite, was it 15? Going on 15. Anyway, really good result. Not really huge stents, but good result, but it requires monitoring, and when the patient is symptomatic, we bring them back and investigate and successfully treat it. Now, I know that we're on the cutting edge of doing these things because we don't have a big series. I have many more patients that I could show you where the IVUS has helped and where we've done what we can to angioplasty. The angioplasty has always worked, and when I say this, recurrent swelling and discomfort in a patient who has venous stents, you must look into it more than just a percutaneous ultrasound, because invariably you're going to get a report that the stents are patent. And every time we've taken these patients back to the cath lab, and it's usually jugular approach, because we don't like to go in popliteal so they can get up and walk around right away. Jugular approach, keep them anticoagulated, no need to change the Coumadin. You just go down and troubleshoot it, treat it with a balloon, a cutting balloon, what it requires, and it's a couple-hour procedure, if that, and then they can go home, and I've never seen the symptoms fail to respond to this. So I think it's our obligation to take care of these people when we're putting these stents in, and I feel very strongly that people who are putting venous stents have to have a system to follow up these patients. You can't just turn them out in the world and hope that they get help, because what will happen is they'll go to other physicians saying their leg hurts, and the doctors will say, "Are you sure they're venous stents? Are you sure they're not arterial stents?" I mean, they actually almost tell the patients that they're lying to them, that they couldn't possibly have venous stents because they've never heard of that. And then, of course, their ultrasound people don't know how to look for problems. So it's really important that those of us who are doing this form a cadre of people that are a national center of excellence to, help these people who are living now all over the United States. Okay, thank you.
Thank you. And you have to wonder whether or not drug-eluting stents and drug-eluting balloons are going to make this problem much easier to manage.
Oh, I hope so.
So we have one last talk for lunch. It's actually lunchtime. So I think what we'll probably do is where is Dr. Adler? Do you mind going first after lunch? Okay. So everyone break for lunch. We'll see you back here to start the afternoon session at 1 o'clock, and we'll start with Dr. Elder. Thanks very much.